Assalamu alaikum. I'm Dr. Amna Pirzada, co-director of the communications team at Ventilators for Pakistan. I welcome you all to the sixth session of our COVEB series, where we will be discussing dentistry in these times of COVID-19. Our experts will be shedding light on how COVID has influenced practicing this high-risk profession and their insight regarding the changes it has brought. I would like to reiterate that this session is part of the educational activities taken up by Ventilators for Pakistan. From its humble beginnings in an effort to support the healthcare system of Pakistan, VFP has now become a name of its own, thanks to the visionary guidance of its founders, Dr. Sabah Akhtar and Dr. Rabiel Tariq, as well as the unrelenting efforts of all of its team members. Every week, we like to put a spotlight on one of our teams and the work that they have been doing. However, this week, we'd like to take a moment to pay tribute to all the healthcare workers that we have lost in this fight against COVID. It's truly remarkable that doctors and all our healthcare workers got straight to work, combating a disease that was unpredictable, highly contagious, and unfortunately, in some cases, fatal. What amazes me the most is that healthcare professionals, a community that bases its practice on evidence, on research, on the known, didn't falter and did not hesitate to deal with the disease that had so many questions surrounding it, so much that was uncertain, and yet they waded into the unknown. During this pandemic, our champion health workers bravely faced this deadly disease. Despite the most serious threats, they stood at the front and were struggling to save other human lives. Their selfless sacrifices are a pride for this country. This Independence Day is named after the healthcare workers who were martyred while performing this great karma. We pay tribute to them and their respected families from the whole nation. While millions of Pakistanis took refuge in the safety of their homes, our courageous healthcare workers took to the battleground to stand tall against an inconspicuous enemy. The risks were catastrophic, but nothing was greater to them than their devotion to save humanity, not even their own lives. Their valor and sacrifice is a triumph for our nation and a defining moment for the future of Pakistan. We at VFP dedicate this Independence Day to honor the heroic efforts of our healthcare martyrs who died fighting for us on the front lines of the coronavirus pandemic. On behalf of our country, we salute these everyday life heroes and their respectable families for putting the lives of others before their own. Salute to our martyrs in white. Professor Ijaz Ehsan, Professor Nazir Hussain, Dr. Muhammad Salim, Dr. Sana Fatima, Dr. Salman Tahir, Dr. Hafiz Maqsood, Dr. Zia, Dr. Asif Ali, Dr. Ali Nazir, Dr. Husne Ahmed, Dr. Basit Kafoor, Dr. Rahat Maqsood, Dr. Ghulam Hussain, Dr. Asif Mughal, Dr. Anwar Sulehri, Dr. Riaz Islam, Dr. Musharraf Iqbal, Dr. Mushtaq, Dr. Naeem Akhtar, Dr. Gulzar Ahmed, Dr. Saida Asma, Professor Anwar, Dr. Syed Nasir Ali, Dr. Wasim Mushtaq, Dr. Qamar Khalil, Nurse Parveen, Dr. Munawwar Javed, Dr. Akram Qureshi, Dr. Tanveer Akram, Dr. Irshad Nabi Sandhu, Dr. Muhammad, Dr. Ghulam Mustafa, Dr. Salim, Dr. Imtiaz, Dr. Noor, Dr. Falak Sher, Dr. Javed Bajwani, Dr. Khalid Masood, Dr. Sikandar Saleh, Dr. Abdul Qadir Shah, Professor Naqash Sadiq, Dr. Rabia Tayyab, Rangeen Khan OTA CMH, Dr. Akhtar Hussain, Dr. Umar Daraz, Dr. Musaddiq Hussain, VC Nishtar, Professor Mustafa Kamal Pasha, Dr. Ghazala Shaheen, Dr. Muzammil Abbas, Dr. Ramzan Bhatti, Nurse Sadaf Jamil, Nurse Rubina, Dr. Abdul Qadir Sumro, Dr. Furqanul Haq, Dr. Zahoor Sheikh, Dr. Zubaida Sattar, Dr. M. Nawaz Guhati, Dr. Asad, Dr. Fasihuddin, Dr. Parveen Mufti, Nurse Amreen Khalid, OPD attendant Numan Ahmed, Dr. Nishad, Dr. Muhammad Isaac, Dr. Shafqatullah Sheikh, Dr. Tahir, Dr. Iram, Dr. Yunus Channa, Dr. M. Isaac Malik, Dr. Abdul Razak, Dr. Khanzada Shinwari, Dr. Azam, Dr. Phakchand, Dr. Aurangzeb, Dr. Abdul Qayyum Masood, Dr. Javed, Dr. Abbas Tariq, Dr. Kashif Nisar, Dr. Faisal Qureshi, Dr. Shah Alam, Dr. Subtain Anwar, Dr. Saifur Rahman, Nurse Musarrat Dilbar, Paramedic Ashraf, Dr. Naeem Agha, Dr. Aslam Mengal, Dr. Zubair Ahmed, Dr. Shah Wali, Dr. Ashraf Awan, Dr. Mohsin Awan, Dr. Fazil Awan, Dispenser Haji Dilawar Khan, and Haji Munawwar Khan, Dr. Osama, Dr. Professor Khalid Naeem, Dr. Ikhlaq Ahmed, and Izhar al-Haq, known as Izhar Chacha, Senior ENT OT Assistant at PIMS, and Zafar Iqbal, Chief Technician OT, Children Hospital PIMS. Here is a short tribute to our martyrs in white. May we all have the resilience and the good fortitude to weather these trying times. Now, without further ado, I would like to introduce my co-host for the evening, Dr. Mavish Erkan. Over to you, Mavish.
Thank you so much, Dr. Amna. Assalamu alaikum. It is an honor to co-host the COVEB educational series. I'm the co-director of the academic wing for VFP and also the co-founder for Yarden Foundation. My sister Maha American and I, we founded this organization about a little over a year ago with the sole intention of helping different sections of our society. We currently have 3 running programs, but I would like to mention our dental program today, which is our pioneer initiative. Under this, we organize dental camps to create oral hygiene awareness, conduct free dental screenings, and provide free dental treatments in underprivileged communities and schools in collaboration with different hospitals. We initially began by visiting various summer schools and camps in Islamabad, including TLC Daycare Center, Westminster School, Children's Preschool, and Honeybee Summer Camp, with the intention of increasing hygiene awareness among children by especially teaching them the proper brushing techniques while simultaneously ending the fear of dentists among them. In an attempt to make change, we then decided to target marginalized communities in our society for whom these facilities are out of reach. We visited orphanages such as SOS Village in both Rawalpindi and Islamabad, as well as the underprivileged schools, including Hunehar Welfare School in G12, Mashal Model Charity School in Bari Imam, where we conducted screenings for about 800 children, Gateway School in Dog Saida, which was an open camp for the entire area, and many more places. By the grace of Allah, so far we have organized camps for over 1,300 plus children and also made sure to provide the necessary treatments. Due to COVID, however, we had to postpone all our other upcoming camps and events, but will gradually conduct them in the time. Now I would like to mention personalities without whom this web series would not be possible. The patron-in-chief for these series is Professor Emeritus Lieutenant General Mahmood Akhtar, Hilal Imtiaz Military. And our patron is Professor Dr. Samia Naeemullah, recipient of the President of Pak Gold Medal by Pakistan Pediatric Association. Thank you, ma'am and sir, for your support. I would also like to take this opportunity to particularly thank Rawalpindi Medical University, which has accredited these education series for all of you to enjoy. Thank you to the Vice Chancellor and the medical education team of RMU. Over to you, Dr. Amna.
Thank you, Mavish. I would now like to introduce our first speaker, Dr. Samir Riaz Qazi, consultant oral and maxillofacial surgeon. He was the best graduate of the class of 1990 at Demont College of Dentistry, Lahore. He then pursued his fellowship from the Royal College of Surgeons from Ireland, after which he joined Lahore Medical and Dental College. He then pursued an MPhil in education since he has a passion for teaching, and has also been a part of the faculty at CMH Medical College, Lahore as an associate professor and the head of department at the Maxillofacial Department, CMH. During COVID-19, Dr. Samir was successful in establishing workflow and airborne infection control recommendations for essential dental care in Pakistan. His publication was used by the Ministry of National Health Services, Pakistan, to release an official document for DHCWs, and is now also serving as a benchmark to bring necessary changes in dental colleges and hospitals to reopen them for routine procedures. In addition, Dr. Samir R. Qazi has numerous publications under his belt and is a valuable asset to the dental community. Allow me to welcome Dr. Samir to our webinar. Participants are requested to please send in questions you have or any points you'd like to be discussed by leaving a comment in the comment section on our live video so Dr. Samir can address them. Thank you so much for joining us all. It's an honor to have you as speaker tonight, sir.
Thank you very much for this wonderful introduction. I've never been introduced so well before, so thank you so much. And it's just a real pleasure and honor to be here. It's really good to see the work that you do, and it's good to see that you've innovated and you're doing this during the pandemic, which I really love. And one of the people that you mentioned at the very beginning, Professor Ijaz Hassan, was very dear to me. So thank you so much for remembering all our colleagues who've passed away. And I totally agree with you, Amna, when you said in your initial introduction that so little is known or was known about this disease. But fortunately, we now sort of a few months into the pandemic, we know a little bit, and fortunately, things in Pakistan are much better. And I'm not going to go into a lot of the basic details, but I'm going to try and share my screen and a presentation that I have for you. I hope it all works. The share screen. Okay, ladies and gentlemen, I hope you can see my screen. And now, the main issue in dentistry, as we know, are these aerosols. Before COVID, we were not prepared for airborne infection precautions. But what happens is with our instruments, you can see these droplets, but you can see the thing that you can see are droplets basically that are going to sort of turn into aerosols. Droplets are affected by gravity. So they're going to fall down and stay there for 2-3 days. The COVID's going to stay there, the coronavirus. The aerosol is not affected by gravity. So at the edges of these the droplet particles, which are greater than 5 microns, they're turning into smaller particles that are not affected by gravity. And then they're going to stay in there for about 3 hours or more. And they're going to settle down on surfaces again, survive there for 2 to 3 days. So this is an issue. Aerosols are a big issue that we were not really prepared for beforehand. And even some of the other devices like the triple syringe, when you use these sprays, again, aerosols are generated. And things like radiographs that are really non-aerosol generating procedures, but the patient can gag or cough during this, and that generates aerosols. And as dentists, we all know that patients can gag or cough at any stage. So even non-aerosol generating procedure can release aerosols that are there in the air, and you can inhale them. This is the main issue. And the precautions we were using before and for dentistry we're not really prepared for it. And this was the content that I was asked to talk about, and I'm really glad to have something to go on. And I looked at the topics that I was given, and I sort of reorganized them because a number of these things related to patient management. And the first thing was teledentistry, and we know the usefulness of this, of screening patients beforehand, not only for COVID, but for their symptoms, to try and evaluate how urgent their treatment is. And this is the second thing. What are emergency treatments? And what are sort of urgent or non-urgent treatments? And this topic the documents. For example, I'm just going to show you this document for a second. By the ADA, which defines what a dental emergency is, and I've circled the procedures in red that generate aerosols. So even emergency treatment can involve aerosol generation. So there are algorithms available now that will tell you, what is urgent, what is emergent, what is, emergency. But the thing to think about is that if this carries and you say it's non-urgent, then it's gonna 3 months later turn into a root canal. You needed a small procedure before, and now it's a more extensive procedure requiring more patient contact time. And it's a more invasive treatment anyway. You may need to start using antibiotics, which you don't really need, but for root canal treatment. But so delaying treatment sort of leads to more extensive treatment, and it doesn't solve a lot of problems in dentistry. What is the home management of dental problems? There is no real home management other than minor pain control. And antibiotics are only indicated in dentistry where infection has gone out of the bone into the soft tissues and gone into the facial spaces. That's when you give antibiotics. I think that needs antibiotics. You need a procedure. You need to clean that area or do a filling or a pulpectomy or something like that. So we got to really think about what urgent and care is and which things can be delayed. And this is a topic which is another day's discussion. Again, a lot of information is now available to help you decide, but I think the decision has to be made, based individually on what the patient, issues are, and then you have to decide yourself. One of the interesting things in this is fear and anxiety of patients about visiting a dentist. And we did a study. I wrote these guidelines, and before that, we did a need evaluation study. And dentists in Lahore, a large percentage of them were not even following basic standard precautions of infection control, let alone precautions for COVID. And so you can imagine the anxiety that you'd have going to an average dentist who doesn't know about it. And this is the answer to this question as well, because as long as you've taken precautions, you can reassure patients. So now you can, and the communication is key, obviously, but patients are anxious anyway. And the issue of missing patients' anxiety has become a little, bigger because on the phone, when we do the tele, consulting, you tend to miss anxiety. I tend to miss anxiety at an appointment when I see the patient. Is that it's only when the patient walks in for the actual procedure that can you see them that you realize how anxious they are, really. So you can try and reassure them as long as you're taking precaution, at least about the COVID anxiety. And then I strongly recommend the use of pharmaceuticals. Oral anti-anxiety medication works very well for anxiety, in addition to all the other anxiety reduction protocol and measures. Now, how to approach, well, okay, yeah, we've talked about this, but how to approach PEDS patient, I have no clue about, totally, absolutely. Our PEDS patients are very difficult, and with all of this PPN here, I have no idea. And if any of the participants have any suggestions, please, I look forward to you sharing them with me. So I'm not going to be addressing this issue at all. How COVID has affected dental practices is what I'm going to talk about in a minute. And I'm so happy that I was asked to talk about facility and equipment considerations and environmental infection control, because these are the two main things that we need to discuss. So thank you for including this, and we'll be talking about this presently. And monitor and manage dental healthcare professionals is interesting because there is a lot of issues, and we'll talk about them, how dental practices are affected as well as healthcare professionals. But basically, we need to sort of we've started working in teams so that one team is isolated from another one. So if one catches COVID, the other can continue to work. You can work in shifts and so forth. We have to minimize the number of, people that are present in the clinic, because the main risk of COVID now, because you can take all of these precautions, so actually getting COVID from a patient, the chance is very low. The main issue is all the staff in the clinic come from different backgrounds, and they have a lot of risk of catching COVID from, their personal environment. So, and then they all get together in the clinic. So this is where the COVID is going to spread from one dental healthcare personnel to another. because we're taking adequate precautions. A lot of us are taking adequate precautions for against COVID when treating patients. So this is a big topic as well, and we will touch on this in different places in the presentation. Now, another interesting thing, PPE protocol in well patients and in patients with suspected and confirmed COVID-19. No, we're not treating. This topic should be PPE protocol for aerosol generating procedures and non-aerosol generating procedures. Remember that the government of Pakistan also recommends that you don't treat COVID patients or who are highly suspicious of COVID. And this is the genuine situation in which you can try and defer or delay treatment and give painkillers and possibly antibiotics in consultation with other doctors to try and not do. In case you need to treat a patient who's suspected of COVID, then you absolutely avoid aerosol generating procedures and manage with non-aerosol procedures. So basically, we need to discuss precautions for aerosol procedures and non-aerosol. Finally, risk of surgical procedures. This was an interesting topic, and what I'm going to say is any aerosol generating procedure that you cannot apply rubber dam becomes very high risk. So surgical procedures are like this. You can't apply rubber dam. There's saliva, there's blood, there's bone flying all over the air, in the air. And so, if you can't apply rubber dam and you're doing an aerosol procedure, then they become very high risk. And we're going to be talking about measures on how to reduce this. And this is one of those situations where you could even think of having a COVID test done for the patient, 48 PCR COVID test done for the patient, 48 hours before. Risk of, in procedures where you can't apply rubber dam, it's a long aerosol generating procedures. So you justify it, I believe, in asking the patient to have a COVID test done 48 hours before and then go ahead and do the procedure once negative. In addition to taking all of these other precautions that we'll be discussing. So, well, the first topic really, how has COVID impacted dental practices? And the first thing is a lot of practices have had to close. Initially, during the shutdown in March, a lot of practices were closed and a lot of dentists didn't have the finances to survive because basically we daily wages. And so some of the practices are still closed. A lot of them opened up as well. So there's been havoc played with the lives of dentists. And this is one of the things that has forced us to get back to work all over the world because of the financial concerns. Patient numbers in our study had gone down by 80% when we did this in March. So this was at the height, and then things continued like this for a couple of months. And then patient numbers are coming back up again, 80% reduction. But for the non-qualified doctors, the quacks, the reduction was only around 50%. So a number of practices, when I said some of them closed, a lot of them stayed open throughout. There was no effect. The pandemic had absolutely no effect on these practices. These include a number of these non-qualified practitioners. And their numbers had reduced as well. And this was their main complaint that, patient numbers had gone down. Subsequently, earnings had gone down. The issue with fee and earnings is obviously there's been a big impact on earnings. I can barely make enough to pay my bills. And some months I don't even make that nowadays. And the issue is the fee. You can't charge enough fee. The issue is about scheduling and the time. Because after a procedure, it takes half an hour to 40 minutes to sort of disinfect the surgery, get it ready for the next one. So on average, a procedure is taking twice as long as it used to. So you cannot schedule as many patients during the day. And subsequently, and you can't expect them to pay for that extra time because dental charges are high anyway. So you can try and add a small percentage to your charges to cover the cost of the extra equipment, PPE and stuff. But basically, patients can't really afford to pay for that extra time. So the hit has to be taken by dentists, unfortunately, and is being taken by dentists. And again, as I mentioned earlier, dentists have started, we working in teams, different sort of options are being done. The idea is basically to minimize the number of people present in the dental clinic at one time. And junior doctors have been affected the most, I think, because fortunately, relatively senior people like me are affected less because in case a patient during the pandemic wants to go and have treatment done, they want to have a definitive treatment done by a qualified person, and junior doctors don't inspire that sort of confidence usually in patients. And I've been in contact with a number of doctors who sort of had to sort of change their professions or thinking about it. And so it's been a really, really tough time for junior doctors, I think. And they are still, going through this phase, even though the pandemic is better. Now, we've talked a little bit about anxiety, but the anxiety is present on the doctor part as well, because it's very difficult dealing with patients, and our working conditions are so tough because you can't breathe with all of those masks. After about half an hour into the procedure, your protective eyewear is fogged up. You can't see anything. And in aerosol procedure, you can't even change. Non-aerosol procedure, I frequently change my glasses. But in an aerosol procedure, even that's very difficult to do because you can't exit that room and you can't open those glasses because of the aerosol will get into an airtight thing. So it's very difficult, and you can't even do as much work anymore. Maybe that's age related as well. Young doctors probably can just carry on working as if nothing happened. But the pre-visit assessment is an interesting thing which I really like, because what I'm personally doing nowadays is that not only am I screening for COVID symptoms and evaluating the urgency of their treatment, but once we've decided that treatment has to be done, I go over all the pre-operative, pre-procedure instructions, the intra-procedure instructions, and the post-operative instructions with them on the phone one day before the procedure. Patients love it. A day before, they know everything. And it takes me about half an hour, usually sometimes longer, to do this. But that time is so well spent because the patient contact time in the clinic is then very little. I cut off, a long time ago. I just spent 15 minutes talking about instructions for afterwards. Pain control has to be discussed in detail and so forth. So this is a good change in some ways, even though we are not mentally prepared. We haven't scheduled time for these phone assessments, which take a lot of time in the clinic as well. But it's a good thing, and we need to sort of figure this into our routine, because this is one of those changes in dentistry that's going to stay. Similarly, airborne precautions that we're going to be talking about are now probably a part of dentistry. I find it I find it amazing that we were able to actually do these procedures with those plain masks, and we were exposing ourselves to so many things. And then clinic reorganization is what we're going to talk about next, and we're starting this off because this is the main impact. The clinic has to be reorganized totally, and this is going to stay for long term. And this is one of the main parts of this presentation today. Just as a short reminder, the standard precautions for infection control are very simple. It's all these 5, 6 things. Hand hygiene and respiratory etiquette in the clinic nowadays is that everyone wears a normal surgical mask throughout. So if you're coughing or sneezing, you sneeze doing it in the mask, and normally it's that you do it in your elbow or the sleeve. But we're going to be talking about these two main things, PPE and environmental infection control. The rest, sterilization has stayed the same. Disinfection, which comes under environmental control, we are going to talk about. And the rest is about the same as before. So the way we're going to go about this presentation is to first talk about clinic reorganization and the infrastructure changes necessary, which includes creation of zones. Ventilation is the main topic. And then we talk about that patient flow management, how to manage patients, then some requirements of PPE, and then some protocols or ways of or guidelines on how to go about doing aerosol procedures, non-aerosol. AGPs are aerosol generating procedures, and then non-AGPs. And possibly a few words about disinfection and waste disposal. Is going to be a longish presentation, and I'm going to ask the organizers to interrupt me as soon as there's some questions to answer. So this is an overhead view of a dental surgery prior to COVID. And it's a small surgery. In the research that we did, about 60% of the clinics had one outside wall. They were in a big commercial kind of an area with one door opening into a reception, and then another door sort of opening into a surgery area. And now the surgery has all of these things. And during COVID, if you actually perform an aerosol procedure in this, having a partition where when you close the door and the aerosols stay in this room is very important. And a lot of surgeries do not even have a solid partition between the reception area and the surgery. So anyway, this is just an average clinic. When you close the door and it's all sealed up, and there's an aerosol down. Now you need ventilation to get rid of it, and we're going to talk about that basically. But the issue is that that's going to take a while, and during that time, the droplets and the aerosol is going to settle on these everything in the room. So everything will get contaminated. If there's no solid partition, the aerosol is going to go out and then contaminate everything, and it's going to survive there for 2 to 3 days on most surfaces. So the basic first thing that needs to be done, if we just look at the surgery first, and we look at all of these things, because everything that's in the surgery has to be disinfected after an aerosol procedure, which takes about, this upper surgery is going to take about 45 minutes to do. This lower one will take about 15 minutes to do, because we've removed everything, even the cabinets and all. So now it's easier, it's actually doable. So this is the first thing that needs to be done. Similarly, all clutter has been removed from the reception area. I'll just zoom into this a little bit. So this is the reception area. And what we're suggesting is that this be turned in a small clinic like this into an area where you sterilize instruments, because usually what is happening is that there's a small counter here in the surgery, and there's a small sterilizer that is sterilizing instruments. So there's no waiting now inside the clinics. The waiting should be outside here. So what we're suggesting is that this red area is for cleaning of instruments, and then this yellow is for packaging and sterilization, and the green area is for storage of these instruments. They should be stored in sealed sort of drawers or boxes or containers so that aerosols cannot get in. Again, this blue desk is the reception desk, which has sealed drawers so that you can store materials and stuff into it. And these gray baskets are the waste disposal baskets. You need a sharps box, you need a household waste disposal, and then you need a contaminated waste disposal. Nowadays, we also need usually a fourth basket, which is for disposal of reusable gowns and stuff, in case you're using reusable PPE. So you may need to, according to your situation, have an extra basket available as well. So this is just a small clinic. A lot of clinics are much bigger, and obviously they can have different zones or areas assigned in different rooms, for all of these activities. And one of the zones that needs to be created is called the triage zone, where patients are initially evaluated when they present to you. The appropriate places are just inside the door, at the reception, or just outside the door. And a healthcare worker initially evaluates patients, at the triage area. Now, the donning zone is where you put on PPE before a procedure. This has to be a clean area of the clinic. So only suitable area is, in this sort of a situation, is outside the door, near a sink, because you need to wash hands and so forth. And sometimes you can have an ante-room or a separate donning room if area is available in the clinic, where there are hand washing facilities and all the PPE is stored in that area. Sometimes there's an ante-room to the clinic or the surgery where you can have a donning and doffing zone, which is the next one, the doffing zone, where you take off your PPE. Now, this makes that area into a dirty part of the clinic. If it's donning and doffing are happening in one room, then they have to be on either side of the room and assigned clean and dirty area. In this sort of a situation, as we see, the only suitable place is just inside the door. This is where you take off everything, and then you disinfect your shoes, and then you step out into a clean zone. So this doffing area should ideally be in a well-ventilated part of the clinic. You need to have exhaust fans there, basically. The waiting area now is recommended to be outside the clinic. You don't ask patients to wait inside. In case they're presenting to you, you can have waiting area outside the clinic. You can ask them to wait in their cars. When you're ready to see them, you phone them. Even if a patient walks in and presents, you get their number, you ask them to wait outside in their transport or whatever, and then you call them when you're ready for them. So no waiting inside. In case you have a large enough area, you can have chairs 6 feet apart. You can have good ventilation in the waiting area, and you can have patients waiting if necessary inside as well. So looking at the zones that we've created in the clinic, the triage, waiting, donning and doffing areas. Surgery is the dental unit area. It's called the surgery. And we've sort of cleared that out of all the clutter. And then the storage area has to be in a clean area place, where ideally in a sealed area. And this can be part of any of the other clean zones. Anteroom to dental surgery, we talked about. You need to usually have a changing room where people come into the work. You expect them to change into sometimes clean clothes. So changing room with possibly showering facilities after the aerosol procedure, no matter what precautions we take, the virus is going to be in our hair, on our clothes, on any part of the exposed skin. So having a shower is the best way to get everything nice and clean. Then you only need to protect your eyes and mouth. That's it. And eyes, nose, and mouth. The rest you can just clean off. Uh, it is a requirement now that the dental clinic has to provide fresh, clean laundry to the dental healthcare workers. So you need to have a laundry facility now. And workers should actually change into fresh clothes or at least an overall or coverall when they enter. And then dining areas, again, because you can't wear a mask in a dining area, so it needs to be a well ventilated. You need to have precautions. You can ask healthcare workers to actually have their food in their cars and so forth. So we need to think about that as well. So we talked about removal of cluttage. Ventilation, we're going to talk about next. Six they may need to be installed in the clinic, where you need to wash hands all the time. And then the two most important things for reducing aerosols are high volume suction and rubber dam. In the research that we did, only 33% of the clinics had high volume suction and rubber dams. So the more than 60% did not have this in Lahore. And this was just unbelievable because these are the two main important measures to do. Finally, you need to get some supplies, obviously, for all the disinfection. And you need to have a disinfection trolley ready in the clinic all the time with two disinfectants on it. One which is non-toxic to human skin for counters and for handles and switches and stuff like that is commonly done. And then one disinfectant that can be used for floors and toilets and things that are going to be washed clean or where hands are not going to be contacted. We can talk about that a little later in the presentation. So this trolley has all the equipment necessary to do your routine disinfection, which has to be done all day in the clinic. So ladies and gentlemen, we've just talked about this first step, which is creation of the zones. We're right up here in the presentation. I'm going to ask the presenters in case the organizers, in case there are any questions. Otherwise, I'm going to move on to the ventilation. We'll again
No, sir.
Okay.
We currently don't have questions about the organization of the clinic. We do have questions coming in regarding the other topics that you're going to touch upon. So once you talk about them, I'll pose these questions to you.
Sounds great. Okay, so we're looking at this top-down view of this dental clinic again. And this has one outside wall. Air is coming in, and then it goes out, possibly through an exhaust. This is the only thing you can do. This is a totally inadequate ventilation of the clinic. You can have additional fans placed in the room to direct airflow in this direction where clean air comes in from one side. If you have two outside walls, then you can have an exhaust, on this one outside wall, so there's a good flow of air through the clinic. This is another option depending on your situation. And when there are two rooms, again, there should be a partition, a solid partition, so that the door can be closed. And the air is coming into this room through a small slit underneath the door, or you can create a small slit through the lower part of the door, where air comes in and then dirty air goes out through a wall exhaust. This is quite a good sort of kind of setup. The first one, in case this one, there's a whole sort of clinic waiting area here, is totally inadequate. Finally, if you have multiple surgeries, obviously more than one, in fact, many exhausts need to be installed to get an airflow which is adequate, which is high enough to get rid of aerosols in a short period of time. You cannot underestimate the importance of fans. Your fans really help airflow. The through the wall exhausts are okay, but the preferred exhausts are called inline exhausts that are used with ducts and that look like this, and then the duct takes the air out, it takes it outside and it's sort of exhausted on the roof generally. So these kind of exhaust systems are preferred. In any case, having some exhaust is very important. There are these, HVAC systems with some HEPA filters and stuff. These are things that you need to install when clinics are being made. And these are big infrastructure changes that I'm not going to talk about. But there are a lot of details here about HEPA filters and their use, which is not really absolutely necessary as long as your ventilation is adequate. And we can discuss negative pressure surgery, but this is beyond the scope of today's presentation, really. And there are some additional measures that are these air purifiers and aerosol suction machines, and then there are these UV lights treatments and so forth. All of these things, and yeah, nowadays fogging is the new fad. They're using machines to fog using sodium hypochlorous acid, and so all of these things are additional measures, but they're good measures to sell your practice because they look good. But the important thing is to protect your eyes, nose, and mouth using just those N95 masks and sealed eyewear. And the rest are additional things that in case you want to do, you can do. Exhaust air from a dental surgery where aerosols are being produced should be exhausted 25 feet away from, outside, on the outside of the building. The exhaust should be 25 feet away from where human traffic is, ideally speaking, or where there are other air entry points into the building. And the air changes per hour is an interesting thing to look at because in case your surgery does not have adequate ventilation, that's going to take 3 hours for the aerosol to get out of it. Whereas in case you have 50 air changes an hour, in about 6 to 8 minutes, you're going to have 99%, removal. 6 minutes, for 99% and 8 minutes for 99.9% removal of aerosol. So this is a very high airflow rate because most negative pressure rooms are at 12 air changes an hour. And then in a negative pressure room, it will take 23 minutes for the aerosol to get out of the room. So any case, so the better it is, we need to aim for something like 50 so that as soon as we stop using our hand pieces in 10 minutes or so, we can get out of the room and then start disinfection afterwards. So the airflow direction we've already talked about is very important, and you can test this by releasing a bit of smoke, closing the door, turning on the exhaust fan, and then releasing a bit of smoke outside the door or a small strip of tissue paper, which should get sucked into the room immediately. And that's sort of a basic way of testing airflow once you've established and got all those exhausts installed. So now we talked about the basic infrastructure changes, and we can talk a little bit about patient flow management. And in Pakistan, about 60 to 70% of patients in the clinics in Lahore are actually walk-in patients, which is something that's totally unheard of in the Western world, where they talk about phone consult, but when more than half your patients are walking in, what you need to do is as soon as they walk in the triage zone, you get their temperature, you get their contact number, and in case that dental healthcare worker who's evaluating them important, ask a few other questions, and then you hand over all this information to them, your patient information form, the consent form, information about COVID and your clinic policies and so forth, and you ask them to wait outside. Remember, our waiting zone is outside in the car or something. And you have the phone number. So now the dental care worker gives this information to the doctor, and the doctor then calls the patient. So we've turned this into a phone consult or onto a tele-dentistry because everybody has a phone. So you call the patient, you do all your pre-operative assessment, you determine the urgency, the cost, you do your consent basically, and you even give them all the post-op instruction I was telling, including that in case they are unwell, they contact and so forth. So this is how you need to manage patients. When the patient walks into the door, when you're ready for them, you call them on the phone. Then there's a tray where you receive all the money, the payment, the forms, everything, that's the pen that you, this is a dirty tray. And then you offer them a hand disinfection. And once the procedure is over and the patient is exiting the clinic, this can happen after the aerosol clearance time, which is called the fallow time is over, which is 8-10 minutes, hopefully at 58 changes, but which, it can be pretty long. And the patient, if wearing any PPE, removes it in the doffing zone, hand disinfection, and then somebody holds the door open and they exit the clinic. The same policy obviously is used for phone in patient management, where you just start off at the phone consult and you just ask them to wait outside in the car when they get to the clinic, and you again call them in once you're ready for them. So we finally actually made it to personal protective equipment. And the most important thing as we're talking about are these respirators and eye protection. The simple surgical mask has to be worn all day. So it's a very important thing to have in the clinic. But the other ones are the N95 or better respirators. I'm not going to talk about details of these respirators today with you. But the warning on them says that, uh, may result in sickness or death, because this is literally what sometimes you feel is happening when you wear them for a long time, because it becomes difficult to breathe. And what I like to say here is a lot of people think that these filters on them, these are the exhalation valves on the thing. They make them worse because they're not filtering the air that's leaving out. They're easier to wear, but the patient becomes at risk because you're breathing out your own air, which can infect the patient. So these are a necessity, unfortunately. As far as eyewear, in case you can get your hands on some sealed eyewear, this is the best, because we know the aerosols are going to go between these glasses and your skin and get into your eyes. So ideally, the eyewear should be sealed all around your eyes. And these are all washable, so they're reusable things, and you can get good quality ones. And as far as these other PPE things are concerned, don't let them give you a false sense of security, because they look good, but seriously, the material that is required to make the impermeable to biological aerosol ran short months and months ago. The material that we have now is not impermeable. The aerosols, go straight through it. So at the end of the procedure, you still have aerosols on your clothes, hair, skin, and everywhere. So the important thing is to again protect your eyes, nose, and mouth. Now, the head caps are such made of such flimsy material that you can even see through them, and aerosols will do nothing. So, in case you think your hair is being protected, it's not. Still, in an aerosol generating procedure, you need to wear all of this stuff. And so, then the surgical mask and shoes need to be changed or worn when patients and staff are entering the clinic. What I mean by shoes is you can disinfect the soles, or you can use shoe cover, or you can change your shoes, whatever suits you. And as far as and surgical mask is being worn in the clinic all day long. Now the respirators for non-aerosol generating procedures, the important thing is again respirators, which is your N95 mask, which you should wear for a non-aerosol procedure as well. Some people are going with a normal surgical mask for an eyewear, but still, because aerosols can be generated when patients cough, as we discussed earlier, or gag, it's best to protect your eyes and mouth. If you're disinfecting a respirator and you're reusing it, then this reused disinfected, so-called disinfected respirator can be worn for non-aerosol generating procedures. It's still recommended that for aerosol generating procedures, new respirator N95 or better N99 if available, and you wear your sealed eyewear, and this is where you can wear your gowns and caps and coveralls, whatever you have available. In case your gown is not impermeable to moisture, then what they're recommending is to wear a plastic apron underneath or over the gown, whatever suits you. And shoe covers, or you disinfect the shoes at the end of the procedure, whatever suits you. Double gloving should ideally be used when you're doing an aerosol generating procedures. And then surgical mask is overworn the respirator. So you're protecting the respirator, which is a 95 mask, by wearing a normal surgical mask on top, and that sort of protects us from droplets getting and contaminating it. So again, on exit from the clinic, the dental health care workers should ideally change their shoes to normal street shoes, and they have to take off their attire and leave it there for disinfection, ideally speaking, and not go home in their clinic attire. And this is another topic that we cannot discuss in detail, just like this topic, which is PPE use and disinfection. Or what you see in these photographs is that people have put their N95 masks into these paper bags and then hang them for 5 to 7 days. And after a week with time, it becomes, we know that coronavirus lasts on masks for up to 5 to 7 days. So in 7 days time, you can open this up, and there are other ways of disinfecting beyond the scope of this discussion. But if there are any questions, I'll be happy to answer them.
Yes, so we have a couple of questions. First of all, a lot of concerns were about PPE and treating patients, given that a lot of COVID patients are asymptomatic. So, does the PPP protocol that is followed in clinics, is it different for Is it different if we're suspecting a patient or if they're asymptomatic? Like, should all patients be considered possible corona suspected patients?
Okay, can I answer this first? And
Of
the
course.
standard precautions in dentistry that I very briefly mentioned used to be called blood and body fluid precautions in the 70s. And then later on, they were called universal precautions. Now we call them standard precautions. And the concept behind them is that every patient is to be considered infected. And this holds true for COVID as well. So the precaution is the same for everybody. We can't identify, this is one of those things in infection control that even in the other diseases other than COVID, there is no way to identify a patient properly. And many diseases are there, patients even don't know, for example, hepatitis C can be there for 7 or 8 or 10 years without the patient knowing about it or being symptomatic. So this is the same. We have to, the whole principle of standard precaution is that every patient is to be considered infected. And unfortunately, during COVID, this principle applies to clinic staff as well. Every staff member is to be considered infected because this is what I was saying earlier, is where the maximum risk is going to come for. So these precautions have to be taken for everybody. And as soon as you know that there's a COVID patient, you don't treat them unless it's a genuine emergency. And so basically, yeah. So I hope I answered that question.
Yes, sir. Sir, the next question is from Sherry. He wants to know how effective is a high volume suction device?
Studies have shown that it can reduce aerosols by up to 90%. It has to be held 7 to 11 or 12 millimeters away from the handpiece, the suction tip. The suction tip should be more than 8 millimeters in diameter, and there should be good flow through it, and then held very close, to the actual aerosol generation. And studies have shown that up to 90% reduction. But the problem is there's no device that does it 100%. And some aerosol is going to get into the air, so you need to have your mask and eyewear.
Okay, sir. Dr. Jawad Kareem would like to know, is it necessary to use external high vacuum suction nowadays rather than unit section?
100%, absolutely, 500%. High volume suction is absolutely essential. You should not be allowed to perform an aerosol generating procedure without high volume suction. 65% of clinics don't have it in Lahore, I know. So yes, absolutely 100% unit suction, you just throw it in the bin.
Okay, sir. Sir, another question. You mentioned pre-visit assessments over the phone. Do you think teledentistry, even with all of its limitations, should be adopted in practice to triage patients, to reduce the number of walk-in patients, and also for post-operative management of patients? Sir, you're on mute right now. Yes, please continue.
It says, can you hear me, guys? I think somebody muted me. Okay, guys. So the question was about, I'm so sorry, you have to tell me what this question was about.
The question is about the role of teledentistry and whether it can be adopted in practice to reduce.
Great. It's great. This is what I'm trying to say. All of these things that you mentioned for pre-op, post-op, taking consent, for evaluation, urgency, 100%. But what happens is about 50-70% of the patients still need to come in, but you've managed to reduce 30-40% of the patients from coming in and from direct face-to-face contact. So it's amazing. I'm using it 100% for all of my cases. I'm just talking about the general population in Pakistan, the general clinics. When you go out and you do this survey, you go onto the streets. So over there, 67% of patients are walk-in. So we need to discuss that, as well. But yes, if your patients are calling you first, it's the most wonderful thing. I think even if when the pandemic is over, I'm going to use that for all these instructions and taking verbal consent and so forth, because it reduces my contact time with patients in the clinic. And they love it when you talk in detail with them. And then you're relaxed, you're not doing a procedure or at the end of a procedure. So you can have long conversations with them as well.
Okay, thank you, sir. That's all.
Healthy dentist-patient relationship is key to, once you have that relationship, that patient is never going to go to another dentist. And communication is key, to all of this. So spending time always pays in the long term.
Okay, thank you, sir. That's all with the questions for now.
Okay, I'm going to attempt to share my screen. I hope you guys can see my screen. So we've actually finished PPE requirements. So we've made some great progress. And this word protocols, infection control protocols. There are a number of words that are similar policy, just saying do infection control. Guideline describes it in more detail. A procedure is description in long detail in paragraphs. And then SOPs, protocols, or checklists. When I think of these words, I think of a document which has a title, which has an area which tells you exactly what items are required. So somebody who hasn't done this procedure can go pick up these items and do it. And then you need to tell them how many people are needed and what sort of PPE they are wearing. And finally, the steps of the procedure, absolutely in detail, not leaving anything to imagination, so that somebody who's doing it for the first time can do it by following your document. So this is a group activity if you're going to make it, and then you need to get feedback on it, you modify it, you post it where it needs to be used. And finally, if in case you need to get an external review, this is my email, which is my name, Samir Kazi at gmail.com. I'd love to look at your protocols. The reason I'm mentioning this is implementation. We've talked about all of these changes, but implementation is based on following these protocols. You need to first make them according to your situation. Every protocol is different according to what facilities, resources you have, or how you want to do it. There's more than one way to skin a cat. Every infection control protocol can be done 10 different ways. So you make it, and I can give you feedback. The requirements for doing aerosol generating procedure are that you have to have adequate ventilation. We know this now. There's good airflow. We haven't talked about negative pressure rooms, but we can't make them in Pakistan. So, but having great airflow, and then the only thing I haven't discussed about ventilation is that you need to seal off. There's an air entry point underneath the door. There's an air exit point, which is your exhaust fan. If it's an exhaust through the wall exhaust, it's probably near the roof. But inline exhaust need to be 6 inches from the floor. And and then you need to seal off all other air entry points, any leakage around the windows, other doors, AC vents, and also that there's negative pressure. You can actually, if you've got 4 exhausts going in your room, you can create a huge amount of negative pressure if you seal off all air entry points. So anyway, adequate ventilation is key. Then you need to have proper eye protection, which we know. Rubber dam, if it can be applied, must be applied. High volume suction must be used. And then the personnel who we know the PPE that you need to wear, the 2 important things, the mask and the eye protection, along with all of the other stuff. And the second assistant who's outside the room does not need to wear all of this extra PPE, can wear routine masks and stuff. So the main thing is to be organized when you're doing this. And this organization is before the patient walks in. So patient is waiting outside in the car, and you aseptically set up the instrument tray and LA syringe and the barriers, and you've dispensed all the materials. The bottles of the materials cannot be opened during an aerosol procedure because the aerosols will get in. So whatever you need, you dispense it beforehand. In case something needs to be passed in during the procedure, then your assistant outside the door should have all of the stuff and can briefly open the door, or there can be slit in the door that can be opened and the material can be passed through. So in any case, you are prepared, you seal off. All of this stuff is now outside on a trolley, outside the door of the thing. And now you can call the patient, phone the patient walks in, temperature is recorded for the patient, shoes are disinfected or whatever, and then the patient is given a gown to wear. Remember, we're doing an aerosol procedure, aerosol generating procedure. In a normal non-aerosol generating procedure, the patient does not need to wear gown and protective eyewear. But in aerosol procedure, the patient should. At this stage, patient should be wearing a mask when walking in. Patients are at maximum risk of aggravating their COVID in case they have it. Because when aerosols are being generated, they can't wear a mask and nose protection or whatever. They inhale it. So in case they have COVID, you're going to worsen their COVID by doing it. So I don't know why I'm saying this here. So the assistant hands their PPE, which is just a gown and eyewear, and then they're seated, and then you do the mouth rinse. Now, there's no evidence to support the use of these antiviral mouth rinse, which is either hydrogen peroxide or povidone iodine. But it is thought that they may be useful, so we're using them. Before this, we were using chlorhexidine. There were a lot of research and studies on chlorhexidine, unfortunately, which said it is beneficial. So nowadays, actually, when I'm doing these surgical procedures, I sometimes give patient both because I know that chlorhexidine is research proven. These antiviral things are not research proven, but are probably useful. So we at least you get them to rinse for 1 minute with either 1 or 1.5% hydrogen peroxide or povidone iodine. And then during the procedure, the door stays closed of the surgery. And the second assistant is outside the door during the procedure. High volume suction and rubber dam, if possible, is used all the time. And then when the aerosol procedure ends, the time has to be noted because the door has to stay closed till that aerosol is out of the room, and then the door can be opened up. So after the aerosol clearance time, which is called the fallow time, the patient can exit the surgery as well as with the doctors, and then the room can be disinfected afterwards. So the key thing is in doffing, when you're removing your PPE, again, remember doffing zone has the maximum amount of aerosol. Research has shown of aerosols because when you take off your clothes, the virus goes out into the air. So the eye protection and the mask should be taken off at the end, once you've gotten rid of everything else. Now, the reality of life in Pakistan is that aerosol generating procedures will be done in a situation where ventilation is not inadequate. And this is in a surgery where there is one outside wall, the airflow is not good, you're not achieving those air changes an hour. So what do we do in this sort of a situation? Even this one is slightly better, but aerosol is going to go all over this clinic and so forth. So with this again, preparation beforehand is key. It's the last procedure of the day. You're doing non-aerosol generating procedures beforehand. This is the last procedure. Again, you've prepared to dispense all the materials. Then they get put in sealed drawers. And as soon as the procedure is over, everybody exits the surgery, including the patient. You don't wait for 3 hours for the aerosol to clear out. You immediately exit, again removing the eye protection and the mask just before exiting the surgery. And then somehow you need to disinfect yourself because it's all over you. And then 3 hours later, the surgery can be entered. Ideally, should be entered the next day, and the entire clinic has to be disinfected because the virus is going to be there for a few days. So again, some guidelines for non-aerosol generating procedures. And the good news here is that you may actually wear the PPE and not change them between patients. And we just talk about that. So again, the important thing is the eye protection. A lot of people are going with a simple surgical mask, a non-sealed eyewear with a face shield. And this is quite okay. A lot of countries recommend this as well. But the preference would be, in case you have an N95 mask, please wear it. And if you're not changing, and then, the rest is the same, you do your mouth rinse, patient does not PPE. And the disinfection, as we're going to talk about later, can be limited to selected areas which have been contacted during the procedure. If you're not changing your attire between patients, then you have to consider your attire infected. And in case your hands touch your attire, then you need to just wash or disinfect your hands and gloves. And you're careful not to touch other areas of the clinic with your attire. And again, if you're not changing your eyewear, the mask and eyewear between patients, then what you do is, after a procedure, remove gloves, wash hands, you adjust your mask and respirator. Remember, we haven't discussed this, but there are these tests to check the seals of the respirators. And so you do your seal checks and you adjust your eyewear to make sure everything is nice and sealed. You again wash your hands and wear new gloves for the next patient. So this is the good news that all that PPE does not necessarily needs to be changed in non-aerosol procedures, as long as you're careful where you contact and where you go and sit in the clinic. So we're really very nearly at the end. The only topic left to discuss is disinfection of the dental surgery. This gives me great pleasure to be bringing this near a close. I'm not going to talk about selection of disinfectant in details, but because this is another full topic. But any intermediate level disinfectant is okay. So you buy these commercial available disinfectants, please stop making them yourselves because they're there. Disinfectants can be low, medium, and intermediate and high level. So the low ones kill viruses, including coronavirus and Hep C, etc., Hep B. The intermediate level ones kill viruses as well as bacteria, including tuberculosis, mycobacterium tuberculosis. And then the high level ones kill spore as well, in addition to all of this. So low to intermediate level disinfectants are great. So just use the commercially available ones. But you need to have one disinfectant which is safe to use on your upholstery, chair, commonly touched areas, and which is generally either hydrogen peroxide or alcohol based ones. Even soap solution works very well, but you need to rub it for a long period of time. And then if Dettol can be used as well for these commonly touched areas. So if something like sodium hypochlorite, which is toxic to skin, should be reserved for floors and non-commonly touched areas. There's a lot of details and on what is suitable for what purpose, which beyond the scope of this presentation. But there is waste as well. I'm going to talk about that a little later. But remember, immersion is a way to disinfect as well. And hydrogen peroxide is quite useful for immersion in addition to sodium hypochlorite. This is a protocol which is what causes anxiety to dentists all over the world for disinfection after an aerosol procedure of the dental surgery. And again, it's we need to have a workshop really to train this. But I'm just going to talk a little bit about how to start this off. So no disinfection is possible without first cleaning that surface. So use disposable wipe, soap in water or soapy water to clean that area, all the commonly touched areas and in any areas of visible disinfection before you start doing it. Number two, remember the technique, the duration and technique, which were mentioned on this last slide, technique and exposure time of these disinfectants. Because the WHO recommends that you use a disposable cloth or a disposable wipe and soak it in disinfectant, then apply the disinfectant using this. And the area should stay wet for 1 minute for maybe all these disinfectants. So this is the tough bit, because if you're using something like alcohol, which evaporates instantly, so keeping it wet becomes difficult for a while. So, so you should have a cloth or disposable cloth or a wipe in one hand, and you probably need to have a bottle of spray bottle of disinfectant in the other hand. You could also have a cup full of disinfectant as well in the other hand. And then you go about doing this. You should start off with it. Obviously, these hand pieces should be removed beforehand. But then all of these whole tubings should be removed from their holders. And you hold them over the spittoon and run water for 30 seconds, to clean. Because of the backflow issue, you need to clean out. This is the dental unit water cleaning. Dental unit water can have a continuous disinfectant irrigation in it already in any case. In any case, you start off by running this water. And then you take one of these tubes one by one and then use that cloth to wipe it all the way down, spray thoroughly, and then clean all these holders, and then you put them all back. And this is where probably a good place to start disinfecting. And then you move along the unit, to the arm, the leg, most of the units, everything needs to be disinfected. This is why I said at the earliest, you remove everything, because these laptop kind of things and everything that's in the clinic has to be totally clean. So you use your combination of spray and this to do it. The floor needs to be done at the very end, and then a second disinfectant can be used for this. And the floor needs to be, sprays cannot be used for the floor because sprays miss out certain areas, so ideally a mop has to be used. And the person who's sort of cleaning it at the very end goes out, if it starts at an area away from the door, finishes just inside the door, and then disinfect their shoes before getting up. So yeah, this is the very briefly the protocol for disinfecting after aerosol procedure. And then few words at the very, very end about waste disposal, because this is very close to my heart. We did this research, and only 28% of the clinics had adequate waste disposal, where these yellow contaminated waste and these sharps need to be sent for incineration. So majority of the this waste is being thrown in the trash, in the humble trash, and we're not even disinfecting it. In case you are doing this, please don't tell me if you are. But then what you do is you don't fill up this trash basket too much, and before you seal it, you spray sodium hypochlorite bleach all over, up to a 0.5% solution. And thoroughly, soak everything. Then you seal it. Then you spray the outside thoroughly with the bleach, the hypochlorite as well. And then you keep it there for a day, because in a day, sodium hypochlorite, becomes ineffective, and because it's toxic before that. And then you throw it all away. So there are ways of doing it. You can use any disinfectant to disinfect your waste. Even during the pandemic, or normal household waste can be disinfected, and you're throwing them, especially from the clinic. But ideally, obviously, they need to be collected, in yellow baskets, the infected waste, anything that's contaminated with blood, saliva, or anything that has been in that aerosol room. So, ladies and gentlemen, this brings us to the end of my presentation. And this is how I decided to sort of, this is the sequence in which we went over this: the clinic reorganization, zones, ventilation, the patient management, and then we talked a little bit about PPE. And finally, some protocols on how to go about doing different things. These were the topics that were given to me to talk about. I hope I have dealt with all of them. But this slide is here in case you think that there is something in these or something else that I can answer any questions that you have. So it will be an absolute pleasure to answer them. So I thank you for your attention, and back to the organizers.
Thank you so much, Dr. Samir. This was a wonderful learning experience for all of us. Thank you for sharing your valuable insight. If it's all right with you, we have a few questions, so I'll just ask you if that's okay.
Absolutely. Fire away.
Okay, so the first question that we have is, should dentists always follow the 30 to 40 minutes disinfection protocol, because most dentists have appointments one after another? Or was this protocol made specifically during COVID?
30 to 40-minute disinfection protocol. I'm sorry, your voice was breaking up, Amna. I did not get that question. Should follow this 30 to 40-minute disinfection protocol. I have no idea what this is. Can you please repeat that question?
I've been asked if there's a specific 30 to 40-minute disinfection protocol for COVID. Is this a standard precaution taken, or is this just for COVID time? Is this the standard protocol that's been followed?
I may have mentioned a time somewhere. There is, okay, the time that they say is 3 hours after an aerosol procedure. Don't enter the room if your ventilation is not adequate, because it's going to be in the air. After that, it's going to be on surfaces. The 30 to 40 minute is that the time it usually takes to disinfect a dental surgery after an aerosol procedure, because you have to do the walls, you've got to do the floor, you've got to do the whole unit. It takes usually half an hour at least, to sort of do it and put on your PPE, take it off, the whole time period. So between patients, you need to schedule an extra 30 to 40 minutes at least. And we generally scheduling 45 minutes to an hour between patients to give us enough time to do it. But it's just how long it takes. If you can do it in 15 minutes, great.
Okay, sir. So the next question is that
after the aerosol is over, you need to have good ventilation. The main problem is you don't have good ventilation. You don't even have 12 air changes an hour. So this means that after an aerosol procedure, you can't enter that room even if you're getting 12 air changes for 25 minutes. So then it's going to take another half an hour to disinfect that area. So
yes.
Yeah.
So the next question we have is from Ms. Amna Talak. She wants to know whether the protocol for instruments is followed as for hepatitis C patients, the double sterilization method.
No, hepatitis C spreads totally differently. It spreads via, it's a blood-borne infection. This is an airborne infection. The precautions are totally different. We were adequately prepared for hepatitis C beforehand if you were following the standard precautions and the needle injection precautions. But this is totally new. This is aerosol, and we were totally unprepared for this. I hope that answers your question, because Hep C, I don't know what the Hep C protocol. Hep C protocol is the standard precaution. There is no Hep C protocol. If you have, so yeah. Thank you.
Okay, sir. Sir, Duresh, I would like to know if there's a specific disinfectant that needs to be used to disinfect N95 masks.
No, disinfectants are strongly recommended. The WHO came out with a document on disinfection of masks. So that document is available. if in case you search for it. And the ways that they've recommended strongly say do not use any disinfectant, any sort of liquid or disinfectant on an N95 mask. The only thing that can be useful is hydrogen peroxide, and that you can immerse the mask in 3 to 6% solution of hydrogen peroxide. And there is a list of 8 or 10 different types of masks that are suitable for this. Because it's not suitable for all masks, the chances are your N95 mask is not compatible. But again, on their website, there is a list of these masks. So if you totally immerse it for, then the thing is disinfected. But this is not a good way of doing it. Moist heat can be used, but not an autoclave cycle. The temperature has to be around 80 degrees and the humidity around 85%. But the normal autoclave cycles are much higher. So even though moist heat can be used and there are different ways of doing it, none of them is practical, and the current sterilizers don't have that cycle to do it. Time is the best way. If you put a mask, if you have a clean paper bag, your assistant holds it open. When you're taking off your N95 mask, you drop it in there, then you label it with your date, name, the number of times you've used that mask, and you leave it for 1 week. Then, after 1 week, it's quite disinfected and clean. WHO recommends, CDC, not WHO, this is CDC. CDC recommends that when you're handling these masks, consider the outside of them disinfected. You never touch the inside of any mask anyway. But the outside, when you wear it, is considered still disinfected, and then you just wash your hands afterwards. In addition to time and disinfectants, microwave radiation has also been used, and there is a way of doing it, but you see, those are all impractical ways of disinfection. So the best way is this time issue, time thing. No disinfectants.
Great, sir. Okay, so Rima wants to know.
Anyway, please go ahead.
Okay, so Rima wants to know how long can an N95 be used if we use the mask rotation method?
Up to 4 to 5 times. Most masks, if they don't get wet during use or are not contaminated, and you storing them properly, then up to 4 to 5 times a mask can be reused. But remember, the reused mask should ideally be for non-aerosol procedures, and for aerosol procedures, if possible, you use a new N95 mask or better.
Okay, sir. So Dr. Jawad would like to know that if teledentistry is put into practice, would this have a role in promoting self-medication among patients? And
Yes.
how should we tackle this?
A big issue. I talk to patients every day, they're doing this teledentistry thing, and they tell me all of these stories where somebody said, "Maine ye antibiotic shuru kar di," somebody said, and I started using these painkillers. They're sometimes using twice the recommended doses or half the recommended doses of these medicines, and different things. The antibiotic use has become absolutely rampant. People on a whim start using medication. So this is totally getting out of control, and we need to sort of try it and stop it. And teledentistry will stop it, because once you talk to them on the phone properly and you give them proper advice, then they stop using the incorrect treatments, and you can guide them better. So teledentist, everything is a double-edged sword, but teledentistry is a fact now. We're using it every day, and it's going to become, I think, a routine thing in dentistry now.
That's a valid point, sir. Of course, that can help patients avoid wanting to self-medicate if they just have the doctor at phone call away or just one click away on the computer. So the next question is...
Doctors who doesn't, because the main issue is doctors are the ones who are giving them antibiotics unnecessarily. So, yeah, so this is a big issue of what can we do in Pakistan.
So the next question is from Dr. Sharbano. What should be the minimum PPE for an intraoral exam? Would a respirator and gloves suffice?
Okay, for history taking, when you're standing 6 feet away, a normal surgical mask is okay with some protective eyewear. For an examination, like I mentioned earlier, a lot of people are going with the normal surgical mask and protective eyewear with the face shield. And a lot of people and a lot of countries are very happy with that. My recommendation to you is wear an N95 mask, maybe a reused one, disinfected one, and wear some protective eyewear, whatever you have with it. So because patient will cough or gag anytime aerosols can be generated. So your nose and mouth protection and eye protection should be good. always.
Okay, thank you, sir. So the next question is from Mr. Mahmood Tariq. How do we check the seal of the respirators that we're wearing? You mentioned that in your presentation.
Okay, so the two ways of doing it. So the when you first, obviously, you wear your respirator and you fit it. Then you put your hand gently covering the entire surface of the respirator, and then you breathe in. And what you should happen is that the respirator should collapse on itself, and you should feel no air leakage from around the nose or around the face. So uh, in those respirators that don't have the exhalation valves, you can do the opposite as well, which is to try and breathe out, which is again to gently cover and breathe out. And the respirator, again, there should be no leakage of air from around the periphery. So these two tests are generally, basically, one of the main issues in Pakistan is that we don't have access to fit testing. First, because respirators don't fit perfectly on everybody's face, one respirator. So you need to be tested with different types of respirators, and then they check your breathing and achieve the seal. And then they recommend, okay, these recommend respirators are okay for you. And once you have that testing, so we don't have that. We just need to try and find a respirator that fits very well, and then do these two tests to check it. If you are using a disinfected respirator, before you put it on, you inspect it all over, especially the foam area around the nose, to check and see if there's been any damage. If anything is wrong, then you discard it or you use another one. So you need to sort of test it by visually looking at it.
Sir, we have another question from Dr. Shahrbano. N95 respirators have a one-way filter, like you mentioned. Is there any way to achieve two-way filtration so that the patient is safe from a dentist-induced COVID infection?
That actually, just use a mask that's a normal N95 one without the exhalation valve. Those achieve two-way filtration. So they're great. I suppose it has to be said, because some of these, we have the other devices which are called P100 respirators. These are big respirators with those filters and everything. Now, remember, they're not medical devices, so even they have an excellent. So they are so good because I've used them, and they basically filter everything, but your breath is going straight out. There's an exhalation valve in them as well. So even though you're super protected, but the patient isn't, and in case you have COVID or your assistant has COVID, they're exposed to it, and you're so near them, you're breathing out straight into them, and the poor people are not even wearing masks.
Sir, we have a question. Nowadays, we have these pre-built walkways outside grocery stores that spray disinfectant on people entering the store. Can such pre-built spray machines be used to disinfect the patient's clothes before they enter the clinic? Would you recommend that? Are there specific disinfectants that can play this role?
Short answer is no. The long answer is absolutely no, no, no. I'm biased. I'm biased because I'm against these devices. These are these commercial entities who want to sell you these devices. So they've created this hype about it. So yes, I briefly mentioned that the new fad nowadays is fog. There's so many fads, and I'm tired in debunking all of them, or doing the myth busting. But in any case, fogging is the new one. So these foggers, what they do is the active ingredient is hypochlorous acid, and which is quite effective. It's a very useful disinfectant. It's not commonly available in Pakistan, so I did not mention it in our presentation. But there's a company that has spent about 6 or 8 million in just getting approvals to use it. So they're now basically really marketing it. And it creates a fog, which is very tiny particles, and they're supposed to clean the air. And then the fog cycles on surfaces, and it can clean the surface as well. Now, remember, all of the surface is not becoming wet with it, so there's an issue. So you need to probably wipe it or something. I don't know. But potentially it can be used to clean the air or help clean the air, this fogging. People are fogging because it's quite safe. So hypochlorous acid is safe to use on skin. There are even eye drops that contain this thing. So it's relatively safe to use on a human. But remember, there's no way to disinfect a human. What are you trying to do? So in case you're trying to sell your practice and you want to use it as a marketing tool, absolutely, it looks great. You're fogging people up and down. But I don't know. I'm slightly biased against all of these things. you still need to have adequate ventilation. Once you have adequate ventilation, once you're taking those precautions about your mask and eyewear, then these are all additional measures. You have these aerosol suction machine, foggers, whatever, you can do it, but I'm generally against all of this fogging stuff.
Okay, thank you, sir. We have one last question. For dental clinics based at home, how can we ensure that the air ventilation exhaust is not infecting the neighborhood?
This is a big concern. Otherwise, you need to make sure that exhaust is about 20 feet away from human traffic area, from any other air entry point into your building or another building. In case that cannot be done, then you take a pipe from your exhaust and you take it up on the roof, and then you exhaust it up there. Again, 25 feet away from any air entry points. So I'm so happy about this question because you're worrying about it. And a lot of these clinics are in commercial areas, which makes it even more difficult to exhaust this air. And in those cases, there is a justification for using these air purifiers and HEPA filters, which are quite expensive. Air purifiers are not very expensive, maybe $250 to $500 or $1,000. So it's not very expensive. And they have these built-in HEPA filters that clean your air. So the air inside the room is being filtered and then put back in. Similarly, you can have these HVAC systems with HEPA filters, which are those duct systems that I showed you a picture of. And they have HEPA filters installed that sort of try and clean this air out. So you can then then you can use fogging to basically clean that air, before you release or before it's exhausted, immediately maybe after a procedure. So these additional measures then can also be employed in case you're concerned. Thank you for that question.
Okay, sir. One last question. How long can a surgical mask be used?
The interesting thing is that even though CDC has come out with this article that I was talking about N95 reviews, there is no information available by any organization about how frequently a mask should be used or changed. So the answer is common sense needs to be used. And this is the answer. If a mask has not become wet, and you think that it wasn't contaminated with droplets or anything like that, then you can continue to use it between patients. And the outside, when you use it between two patients, the outside of the mask should be considered contaminated. So you don't touch it. If you touch it, you wash or clean your hands or disinfect your hands. So yeah, common sense. And then after, when you think it's sad enough, that you just dispose it. And there is no recommended way of disinfecting. There are recommendations for these N95s and other respirators, but for surgical masks, there is no recommended way of disinfection. Again, the method, that 1 week method of waiting with time, is probably the best one. Yeah, sunlight, we're forgetting the use of sunlight over here. Sunlight has UV rays, and UV rays are quite effective, but UV lights, unfortunately, maybe are not recommended. There are so many details. But anyway, what you can do is you can put stuff out in the sun. You can hang your masks or cloths or gowns or whatever, and then you twist them after a couple of hours so that other side. So if you leave things out in the sun for a few hours, they'll get pretty nicely disinfected. So you can try these things. There's no guarantee. Nobody will tell you that this 100% disinfects it, so, but still.
So this is another question from Durish Navar. For trainees, third year and final year students, what protocol should they be following?
For third year students, what?
Final year students, BDS students.
What? Sorry, I didn't get the whole question.
What protocol should they be following when they're in the clinic, like these final year students?
Question is so difficult for answer because this has to be answered by the head of your organization, who I'm sure have their own protocol. But if I was sort of involved in this, so I would have 5 months ago drawn up recommendations and guidelines in detail and given it to everybody in writing, which I'm sure they have, and they should have it. All those things. So this is such a big topic. When I wrote these guidelines for clinics, it was a monumental task, probably worth about 2-3 months of work that I did overnight with my team in about 3 weeks. Now, coming up with answering this question is 1 or 2 months of intense work by a team of people, which will then come up with beautiful protocols for what precautions they need to take in third year and final year specifically. especially when treating patients in big halls, and because the environment is very different. So I'm sorry, it's a very big question to answer, and I'm sure your college has already been working on it for many months.
Okay, thank you so much, Dr. Samir. That's all for today. This concludes our question and answer session. Dr. Mavish, over to you.
Thank you, Dr. Amna. Thank you so much, Dr. Samir Qazi, for coming and giving us such a wonderful session. I'm actually a part of the infection control protocol committee at Shifa, so it was very informative for me. I would now be honored to announce our second speaker for tonight, Dr. Abdul Samad Khan. He's an associate professor of dental biomaterials at the College of Dentistry, University of Dammam in Riyadh, Saudi Arabia. Here, Dr. Samad was awarded Best Researcher of the Year for the year 2018 to 2019 and was successful at getting research grants while also doing collaborative projects with UK, USA, Germany, Hong Kong, Malaysia, and Pakistan-based institutes. Dr. Samad has 64 international publications, 14 book chapters, and is the editor of 2 books. The impact factor of his publications is more than 165, which is the highest for any Pakistani dentist in Pakistan. His area of research interest is synthesis of dental composites, dental adhesives, and periodontal membranes. Recently, he got a US patent application number, which is also related to the synthesis of dental composite. It was Dr. Abdul Samad who initiated the Pakistan section of International Association for Dental Research in 2010 and was the founding member and the first executive director. Since then, he has been arranging conferences, seminars, and workshops from this platform. Currently, he is the vice president and also the president-elect of this association. He is a member of the Academy of Dental Materials USA, editorial board member, and reviewer of many journals. Dr. Samad graduated from Nishta Medical College in 1999, and after working at IMDC and Margate from 2001 to 2004, he completed his MSc in Dental Materials from Queen Mary University of London and got a distinction and Best Student of the Year award. On this basis, he also received a scholarship from the same university for PhD in dental biomaterials. He has previously worked as a research associate for Doxa AB Company in Sweden and came back to Pakistan to join the Interdisciplinary Research Center in Biomedical Materials, ComStats University, Lahore, as an assistant professor, and he was later promoted to an associate professor in 2011. He established the first dental materials research center in Pakistan, and in 2004, he also completed his postdoctoral research from University of Sheffield. Later, he was made research in charge at ComStats and managed to get research grants from HEC, Pakistan Science Foundation, as well as British Council. Dr. Samad was the focal person in HEC for subject of dentistry, member of Dental Education Committee of PMDC, member Faculty Board of Studies, University of Lahore, as well as the honorary faculty member of Queen Mary University of London, Demont College of Dentistry, University of Health Sciences Lahore, Hamdard College of Medicine and Dentistry in Karachi. Since 2010, he has been supervising MPhil, MBS, and PhD students as well. Please allow me to welcome Dr. Abdul Samad Khan for an interactive session where he will be discussing research during the COVID pandemic and answering all your queries. Participants are requested to please send in questions you have or any points that you'd like to be discussed by leaving comments on the section so Dr. Abdul Samad can address them. Assalamu alaikum, sir.
Assalamu alaikum. Thank you very much. Thank you, Dr. Mavish, for such a nice introduction. I'm honored. And thank you to you and to Dr. Amina for inviting us for this online session. And it is an honor for me again to share this session with Dr. Samir Qazi, because he was I learned a lot from him, and especially from this presentation. So for today's session, deliberately I didn't put it in a presentation form because the topic again, research or the dental research is a very vast topic. So we don't know what to say or what we cannot say in just 1 hour or maybe more. So it would be better if there are any queries related to research, dental research, or something else. So maybe if it is in my domain, or if I know anything, so I can share it with you. If I don't know, so I will say sorry to you.
Okay, sir. So we actually have queries.
Take a moment and please tell our participants that when you have any queries, please mention your designation, your level of education, so Dr. Abdul Samad Khan can address your question and your query accordingly. That's just a reminder for our participants.
Thank you so much, Dr. Amna. Sir, we do actually have quite a lot of questions. I would first, though, like to start with why you think research is important for dentists, or specifically related to Pakistan, basically.
All right. Okay. If you see just your today's session, if you'll see, if Dr. Samir Kazi, if he didn't do research, right? Because as he mentioned that he spent almost months and months to establish all these guidelines and all these things. Like, I think it happened due to research. Like, if he didn't do this thing, so we cannot know this thing what he has just shared. So that's why it's very important. And specifically, like, my point of view, which I've been advocating for the last almost 15 years in Pakistan, that why we need research in dentistry in Pakistan, especially in academia, because we have seen, we normally follow the same pattern, all the textbooks and all these things, and especially at a postgraduate level, the projects which we are designing, we cannot publish it in international journals. Why? Because I had a discussion with my colleagues and with my friends, like, why can't we publish these things in international journals? And their answer is that we are just repeating the same thing which have been done like previously. So as a researcher or in academia, we should know what is new in dentistry. We should know up-to-date knowledge, the anything or the innovation or the any new guidelines. Like, so that's why it is important. So instead of relying on others, like, definitely data is available in journals or in magazines and all these things. So we are just treading the same beat, like, okay, we'll get it and we'll read it from there. But if we'll do it ourselves, so we know, like, what is the best for our society and what is best thing for our academic institutes. So that's why I think it's very important for our researchers, or especially for academicians. Like, I know, or maybe definitely this thing, like in your institute as well. Most of our teachers, they are either FCPS, they are MScs, or they're PhD doctors, right? But how much we are doing research we are doing in our institutes? We are just relying on the same thing, on the same textbook which have been published maybe 10 years before. But we have seen, like, in last 10 years, many new things have been appeared in dentistry. Like, especially when we talk about dental materials, those dental materials which we were using in 2000, we are no more using the same thing. So if we do not know these things, so we will fell apart from the rest of the world. And especially, again, when we see our contemporaries, like the other countries in Asia, or don't forget about USA and UK and Australia and Canada, just see other countries in Asia, like Iran, India, even in Saudi Arabia. We have seen, like, I've been here like for the last almost more than 4 years. I've seen how much investment they are putting in at an undergrad level in dentistry for research. Their graduates, they cannot get the degree unless until they will not do a full-fledged research project. And that's how their publication has been increasing. They are getting the US patents, they are getting some other funding from different institutes, and they are getting admission in universities either in Canada or in USA or in UK, just on the basis of their this research background, you can say.
Yes, sir, that's very true. In fact, I remember we used to use amalgam, and we still do continue using amalgam, and we know due to research how inconvenient it is for, and how toxic it is for all the patients, including us as well as doctors. Sir, so when we do research, dental related or anything, so what do you think is the status of the dental journals in Pakistan, and should we go for public publications in that?
It's a dilemma. Actually, when you asked me about this session, and I normally conduct other sessions as well, I don't want to talk negative, but somehow, unfortunately, very unfortunately, when we are talking about research or the topic, just about this question, I have to say my answer is in negative. There are many dental journals, specifically in Pakistan. Some of them, they have a history of more than almost 30 years, 35 years. and some now many dental institutes they are publishing their own journals, but unfortunately none of them are indexed even in PubMed. Forget about Web of Science, forget about Scopus. Like though I don't have any conflict of interest, I'm the part of their editorial board. I'm part of their editorial board, but these journals, they are not even PubMed indexed. Okay, and PubMed index, you can say, is a very basic thing. Like when we talk about the impact factor journals, it's the Web of Science based journals, or the Scopus is another thing, the indexing criteria. So PubMed is a very basic thing. Unfortunately, our dental journals, their editors and their publishers, they didn't focus on this thing, right? Yes, when we talk about the medical journals, some of our journals like JCPSP, JPMA, they both are Web of Science Index journals. Journal of Ayub Medical College, it's Scopus Index journal. Journal of Pakistan Journal of Medical Sciences, yes, Pakistan Journal of Medical Sciences is the Scopus Index journal. So on the medical side, they are working and they are improving their status. And this is the area where the dental journal, they should focus, especially in Pakistan, at least to get the indexing from the PubMed.
Yes, sir. So that's actually very true. In fact, even while doing research myself, I do actually would prefer international journals, especially when we're applying for maybe masters or MPhil, or even when we're in a post, for example, as a demonstrator and we want to be promoted. So we do require international journals. And a lot of people had questions on how to publish these and how to go forward with these international journals.
Okay, right. So it means that they are looking for publications, manuscript. Okay, first we should know what type of the publications they can get. Okay, either it's a research article, it's narrative review article, systematic review plus meta-analysis article. So these are like 3-4 different type of the articles which anyone can get published like in any international journal. So what is the basic thing which you should know if you want to publish in international journal? My first thing, and I always say, read international journals. Like this, if this is what I've been saying in many workshops. Like I can conduct 10 workshop of this type on this topic, but you cannot get anything if you will not read it yourself. So you have to read. I don't know, like in participants, if there are PG students or the young faculty members, how many articles they are reading per day? Like if they are doing a post-graduation in either MDS or FCPS or MPhil, how many articles they are reading related to their subject per day? The more you read, the more you know how to write papers. This is a very simple rule. If you'll not read international papers, you don't know like how to write. So if the basic thing, if you want to publish paper in an international journal, at least read 2 papers per day. Just make it your habit. Like it would take like an hour or so, maybe like during your college time. If there's any break, you just read it on your mobile as well. So that's the first thing. Then there are some other things which you should know. Like if you are going to publish research project, okay. So for research project, to get it published in an international journal, your idea or your project, it should be novel. Okay, don't say this thing has not been done in Pakistan, so that's why we are doing it, right? This is a very common thing which I have been listening for many years. Like people, they are saying, okay sir, we want to this thing, this is a project on glass ionomer and I want to see the shear bond strength of glass ionomer with this thing. Okay, why are you doing this thing? Sir, this thing has not been done in Pakistan. So what's the point? The glass ionomer is same, so the machine which you will use it's same. So you have to design a new project, a novel project. Okay, then your chances will be higher to get it published in international journal. And how to design a project? Again, my first thing, read papers. When you read papers, you'll get the idea like what type of people, projects people they are working internationally or even at a national level. Okay, like suppose whatsoever is your field, either operative dentistry, endodontics, prosthodontics, read your good journal of your area. Okay, and then you'll get to know like maybe in just 10-15 days what's going on in the world, like where the research is going. As you just mentioned, like you were using amalgam. We recently did one study. It's under review process where we did. It's basically a retrospective study, a trend of dental materials, like in last 12 years, and we have seen in last 12 years, especially in last 5 years, there is no new research on amalgam. It means people they don't want to work in this area. Similarly, on the conventional glass ionomer, people they are not interested anymore. Yes, they are going towards the resin modified glass ionomers, or they are working on some adhesives or some other things. But conventional things are no more in market, and people or the researchers they don't want to put their energies, their time, or the companies they don't want to invest their money on these things. So this thing you should know. So how can you design a project? Again, when you read papers, you'll get the idea what is going on, and from there you can find it out, any missing link, any missing question, which on that way you can design your own project, right? One thing again related to this, when I speak to our colleagues in dental colleges or PG students, they say that they don't have resources, especially because we have very limited government base of a public sector dental colleges in Pakistan. Hardly, maybe we can say 6 or 7. Rest all are private institutes. And private institute, they don't want to put money related to research. Obviously, it needs a huge amount of money. Okay, so then why can't we go to outside our university? Like suppose if we are in Islamabad, we know in Islamabad there are 3-4 big universities, like NUST is there, COMSETS University is there, Qaid-e-Azam University is there, and there's a department like microbiology department, molecular biology department, their material science department, engineering department, like as far as my experience, when I started my career in COMSETS University, the behavior, it was so welcoming because they didn't expect that any dentist can do research, right? And when I went to them, they said, "Oh yes, we have this thing, we have this equipment, and they have their own ideas related to dentistry or related to biomedical sciences." And from there, we designed the project. I use their equipment, I use their facilities, and that's how we jointly published. Like you just mentioned, thanks to you, you just mentioned about my publications and the impact factor. I feel very proud. Like out of these 65 international publications, 99%. Sorry, if I would say almost 95% is from Pakistan. Very few like from my MSc and PhD work. The rest, all the work I did it in COMSETS, and still, even for the last 4 years, still I've been working with COMSETS University, and my projects are going over there. My students are working over there, so we can produce some very good papers from Pakistan. It's just we have to go out of from our office and to spend some time and energy.
Yes, sir, you're absolutely right. Which leads me to the question, can a dentist research in another medical field, for example, maybe related to diabetes or mental health or something as such, or is it just specific to every field?
Yes, it's an open area. It's an open area, and like if diabetes is related to dentistry, then obviously you can do research in that area. Like if I can give you the example of I know some prosthodontists in Lahore, or in Lahore, they are working on genetics, right? Because they found some patients who have like edentulous patient, and they went to their families and they found it out, okay, it's running in their family. So they took their samples, they did some analysis, and they found it out, okay, it's running in their family. So it is related to genetics. It's not actually dentistry. So similarly, if you just give the example of diabetes, So dentists can go. Similarly, if any psychological issues or neurosciences. Recently, there was a competition of IADR Asia Pacific region, and there was one presentation from from China, and it was about the neurosciences, purely the dental research related to neurosciences. So it's an open area. And again, one thing related to this, again, I think in our, the organization like PMDC or the universities they put a bar like non-dentist or non-medical person cannot teach in dental institute. I think recently they allowed this thing. I think so. But I've seen like in USA or in UK or in any other country, our teachers for dental materials, for oral biology, for oral pathology, or all from the basic sciences, they are not dentists. They are either chemist, physicist, a microbiologist, molecular biologist, but their research area is related to dentistry, and they are teaching, and they are much better teachers compared to from the clinical background.
Okay, sir. So, sir, if we're sending it into a journal that is not related to dentistry at all, and even our topic is not related to dentistry, it's just generally, for example, based on diabetes and maybe some kind of proposed treatment. So, will they have an issue with the authors being dentists and not doctors?
No issue. Like okay. My publications mostly are in material science journals, okay, and in biomaterial science journals. So there is no issue. It's an open area. Science is just open. It's open for all.
Okay, that's great. Sir, I would also like to ask, basically a lot of people want to know the tips and the characteristics of manuscript writing. And a lot of people do find difficulty because it's different for every journal, but what are the recommended for international journals specifically?
Okay. So here it's a detailed answer. So I'll try to cover all aspects. First, for the publication, you should know what are the different components of any paper, especially if it is a research or original research-based paper. Abstract, graphical abstract, highlights, keywords, introduction, materials and methods, results, discussion, conclusion, acknowledgements, conflict of interest, and references. Okay, so these, and obviously the title as well. Okay, so these are the different components of any research-based publication. So when we are talking about like how to get a good publication, okay, don't say the international publication, you say a good publication. Okay, so you should work on these components individually. You have, like, it's a teamwork maybe, or if you want to do it alone. For the title, okay, for the title, I would say it should be concise, okay, it should be crispy, okay, and it should not be very lengthy. Like the maximum word in title, it should not be more than 15. Don't write 3-4 lines just on title. Don't mention everything in title, okay. So your title should be very concise and crispy. Usually, again, I decide just at the end, just before publication, I normally, restructure my title. Second thing is graphical abstract. What is graphical abstract? Graphical abstract is basically what you have done in your work or your research or in your manuscript. You have to give some schematic or maybe pictorial images of that thing, okay, as the name shows, graphical abstract. So this is recently, like in last 3-4 years, many journals they ask for this, and it's mandatory you have to submit graphical abstract. Some people, what they do, they use the same images which they are using in their result section. It doesn't give a good impression. You have to think about it. You can make, even in any cartoon form, okay, you can think about yourself, like what is the design of your project. You can make some schematic chart, okay, or schematic structure. So you can get these examples from Google and all these things. So graphical abstract is the thing which you should know how to make it, and what things should be covered in graphical abstracts. Third thing is highlights. Highlights again, for the last almost 5 years, you can say, now most of the journals, they ask for this. Again, it's mandatory. Graphical highlights is basically 3 to 4 points of your paper. Like you have to summarize all your manuscript in 4 to 5 or 3 to 5 bullet points, and each bullet point should not be more than 80 to 85 characters, including space. Okay. Second thing, you should not repeat same words or same sentence which you have already mentioned in your introduction or in your conclusion or even in your abstract. So that's another thing you should know, like how to write highlights. As I mentioned, 3 to 4 points. Each point should not be more than 80 characters, not very lengthy, just a single line sentence, a bullet point. And in 4 or 5 points, you cover all your methodology and results. Usually we don't write methodology in highlights. We not just first sentence is about a background, and rest 3 or 4 points are about results. Okay. Then I will not talk about abstract right now, because abstract is the last thing which we normally write it down. Introduction, and this is one of the questions I think you asked me yesterday. Introduction, what type of different components you should include in introduction? There are 3 main things. First is the literature review. Second is the significance of your study or any novelty. Third is aim and objective. And with aim and objective, you can also mention hypothesis. Okay. Now come to the first point, literature review. In literature review, you should not mention, like in details, and you should not go for very basic things, because some few things, they are not established. Now everybody knows this thing. So for, like, suppose again, if I'm giving you the example of dental composites, like there's no need to write it down that dental composites are composed of resin, fillers, and silent coupling agent or photoinitiator. Like people know this thing now. Come straight away to your, just giving a 1 to 2 basic lines of your background of your topic, and then come to the components which you have included. Like suppose if your research is based on 3 or 2 to 3 main topics. Okay, like suppose you are working on bulk fill composite and you want to see the pore formation while filling the bulk fill composite. So you have to give just straight away, start with bulk fill composite. Don't go to the basics of the composite. Bulk fill composite, maybe a couple of lines. Then what are the issues related to the bulk fill composites? Okay, give a couple of lines about those things, and then come to the pores formation while placing the bulk fill composite. So if there is any previous studies, so you can mention it there. So 2 paragraphs about this, and in 3rd paragraph, you can mention what is the significance of your study, why you are doing this study, or either, and if it's a novel, so you should mention, because this is the thing which editors and the reviewers, they want to see, that you should mention this thing, that the authors could not find any study previously or in literature where this thing has been done before. Okay, so mention such things, like, so that's how the reviewers and the editors, they get the idea. Okay, yes, this is, they are going to present something new. Okay, so after this, then you mention about the aim and objective. Again, don't go like in too much detail. Don't repeat or don't mention those things which you are going to mention in methodology. Okay, and then last line, hypothesis or null hypothesis. Then come to the methodology section. Methodology, if ethical permissions are required, so you must get ethical permission before starting your project. And there was one question, how to get ethical permission. Like every institute, they have their IRB or some ethical committees. I think like even in Pakistan, every dental institutes or medical institutes or university, they have these committees. So you must apply, even if if you don't need ethical permission for your work, but you must get permission, that just a letter which shows that this project does not need any ethical permission. Like suppose you are working on lab-based study, which is not required or based on any human tissue or any animals or something like this, but at least you should get the ethical permission that this project does not need ethical permission. But if you need ethical permission before starting the project, well before in time, you must apply for that. Okay, I know every institute in Pakistan. If you don't know, so you just consult it with your supervisors or maybe with your head of institutes. So they will tell you how to get the ethical permission. Okay, so clearly mention if ethical permission has been taken or not. Okay, then second thing is about your materials. If you are doing quantitative analysis or your studies based on experimental work, or if it is descriptive one, in any case, you have to mention in detail what type of the material in any form. If it is on survey-based study, you must mention what like male or female, what was the age, and their ethnic origin, anything. And if it is material based, you must mention each and every material and their company name, because some people or some companies, they feel offended if you do not mention their complete details. Then come to the experimental or the methodology part. So you have to mention each and everything, because methodology section is the main section which you should describe in detail, because that's the area where you can get the from the attention from the reviewers or the editors. Then in methodology section, each and everything should be mentioned, but bear in mind there are a few mistakes which we normally do, like which if you are mentioning any numerical values, do not start your sentence with numerical values. Do not start your sentence with abbreviation. Okay, so these things, very few small things, but people, they notice such things. Secondly, a common mistake which we are doing is to mention about the SI units. Okay, like suppose if you have to mention the SI unit of Rs, so we normally write HR. It's not HR, it's H. In seconds, we normally write SEC, second. No, the abbreviation is S. So these things, they bother reviewers. Like they feel, okay, the person, if he or she doesn't know very small thing, it means they don't know about manuscript writing. Okay, so in methodology, better to mention about your samples, your groups. Description should be there very clearly. You denote them with some name. Those names should not be very complicated, very simple. Group A, B, C, group 1, 2, 3, something like this. Or if you want to give them some abbreviation, so those abbreviations should be very common, not very complicated. But all groups should be mentioned clearly in either in a tabulated form or in text form, but do not repeat it both in text and tabulated form. Lastly, you should mention about this statistical analysis, like what type of the statistical analysis you have done. It should be clearly written. Do not mention only like this, okay, statistical analysis was done using the SPSS version 22 and one-way ANOVA test was done. So you should write a little bit more. What is the confidence level, like what is the p-value, or if there are multiple tests you have used, so mention all these things. Then actually I'm doing very quickly because the next thing is about the results. In result, again, common thing, do not repeat methodology. We have seen this thing that people, they are doing this mistake, that they are repeating methodology in results. Do not mention this thing. Secondly, when you are describing your results, do not repeat same result in text form or in table form and then in figure form. Okay. Again, either text form or in table form or in figure form. There should be a combination of these things. But usually, if you have some numerical values, and a lot of numerical values or quantitative data, so mention that data either in figure form or in table form. And when you are writing it in a text form, better to mention or focus should be on statistical analysis. Okay, because statistical analysis you cannot describe completely in figure form or in table form. So if there are any significant difference or non-significant difference, you can mention these lines in the text form, and rest is given in tabulated form or in figure form. Secondly, when you are mentioning the p-value, so when you're mentioning, I would say when you're mentioning that the difference is significant or difference is non-significant, there in bracket you must mention what is the p-value, either it is more or less than 0.05. Ideally, if you know the exact value, like p-value is 0.03, okay, it is much better. So people get the idea, okay, it means you know what is the statistical result. Other thing, when you're mentioning about the significant and non-significant, very common mistake is that when we are writing the statistical differences highly significant. Okay, there is no such thing, the highly significant. Either it is significant or it is non-significant. Why I'm saying this thing? Because these are few things which normally, take your reviewer to make his or her mind that either this person has some scientific background or not. Okay. So next part is the discussion, and this is the most important part of any manuscript. There, from this part, they normally decide what is the level of any researcher. And there is again very thin line between discussion and introduction, because few things which you can mention in discussion, which sometimes people think, oh no, it should be in an introduction section. Okay, regarding the discussion, as per my experience, the first paragraph, it should be about like either you achieve your objective or not, either what you achieve your hypothesis or not. So first paragraph should be based on that thing. Then in second paragraph, you must mention your most important result. But again, do not repeat your result. The discussion about the most common result, like which you think is the significant thing. Because when we are doing experimental procedures, there are few things which are like pure novel, you can say, and few things we are doing just as a supporting data. We are doing adding some variables to get some secondary support. So your primary result should be in second paragraph of your result. There, what you should do not repeat the literature here. Do not repeat what people have already been done. We are not interested in those things. Right? When you are comparing your result with other research, previous research, we have seen this thing that now people, they are describing their results. Okay, like our study is in accordance with Mr. Flan and Flan, and this, then you can spend like write 4 or 5 lines related to their study. Here's just simple their reference, like our study is in accordance with previous study which was published, like, or maybe you can just give the reference. Fine, if you want to know, we can go to that reference and we'll read it out like what they have done. Because again, we have seen like we are spending sentences just to compare our result with previous results. Then in third paragraph, you should mention your secondary data and about its description. Okay. Again, here you should mention why it happened. Again, do not compare it with your, as I just mentioned, do not compare it with previous result. Discuss it, why it happened like this. Okay. And then last paragraph is about if there is any limitation in your study, okay, or if you want to give any future direction. Common thing when you are mentioning the limitation of study, do not give a huge list of limitation of studies. You can just mention a couple of them and it's fine. Because if you are giving a huge list of limitations, then people, they will ask, okay, it's better to do it again. Okay, you should go back to your laboratory, or you better to go to your clinic and then do it again. So just give a very 2 or 3 things and then move forward. Last section is about conclusion. Conclusion is a summary. In conclusion, do not repeat same sentences which you have been mentioned in discussion, in results, or in abstract. It should be different. Okay. Some reviewers, they like that conclusion should be in a bullet form. Some say, look, it's better to put it in a paragraph form. So both ways are fine. So you can mention in both ways. But if it's in a bullet form, each sentence or each bullet point should not be more than two lines or 3 lines. Okay, and then just focus it on main component of it, main result. Do not repeat your methodology in conclusion, unless until if you are using any novel technique, then you mention, okay, we have used this novel technique and it has given us some significant results or better results. Acknowledgement, you should mention, because authorship is a very tricky thing, especially in Pakistan, like who should be involved as a co-author and who should be mentioning in acknowledgement. But usually in acknowledgement, if you think anyone supported you during your research project, you should mention their name. If you don't feel like they don't fulfill the criteria of authorship, then you should mention their name as in acknowledgement. Secondly, if you took any funding from any agency, you should mention their name, properly acknowledge them, and mention if there is any grant number or any ID for this. Then the next point is about the conflict of interest. Again, you should mention if you have any conflict of interest while doing this study. Maybe especially when you are doing some clinical trials and you are using or you are working on some material, okay, and 3M suppose 3M company, they put you on this project and they ask you, okay, can you do on our material, okay? So you should mention this thing that we have done this thing for 3M company, okay, and we have taken the financial assistance from the 3M company. The last thing is about the references. The references always go according to the journal guideline. Okay, so and it should be properly formatted and in that style which journal has been mentioned. Okay, now coming back to sorry, I'm taking a time. Now coming back to the same thing. When you are writing your manuscript, you should see the author's guideline. Like if you are targeting any journals, suppose Journal of Dental Research, okay? If you're targeting Journal of Dental Research, first read their guidelines, like what is the word limit, what is the figure and table limit for this journal. Suppose if they are saying that the word limit is 3,000, so you should be in that range. And if they are saying that only 4 figures and tables are allowed, okay, and your figures are almost 8, okay, then Journal of Dental Research is not a good journal for you. Then you should see some other journal. So always see the journal guideline before submitting or before finalizing your manuscript. Okay, so you can modify it or edit it accordingly. Secondly, when you are preparing your figures and tables always, it should be in Word document form. Do not submit it in JPEG or in TIFF form. Okay, it gives very bad impression when you are submitting it like this. Figures, see the author's guideline. They have clearly mentioned, I think every journal in their guidelines, they have clearly mentioned what should be the DPI, the resolution of the figure. Some journals, they want like in TIFF form, in JPEG form, in PDF form, or in PNG form. Some journals, they said, okay, we don't need JPEG. We need only in TIFF, and the resolution should be 600 DPI for graphs and 300 DPI for black and white images, of 1200 DPI for any pictorial images. So you have to edit your figures accordingly. Now, like these they are very easily available on Google. Previously, we know, like just almost 7-8 years before, we normally use a Photoshop editor for such things. But now many free these software websites are available where you can put your figure and then they can do it according to your requirement. They can change the resolution, they can change the or resize the figures. So you should know this thing. Like if you are just submitting your figure with 96 dpi and there the requirement is 300 dpi, so editors, they know this thing and then they will get the idea easily. They can go straight away rejection just on a some very basic things. Okay, proofreading and editing is an important thing. Before submitting, very clearly, all authors should read this paper and they should give their consent. Okay, specifically we have seen in last few years, now we are used to use these WhatsApp and messengers and all these things, and now we are using a lot of abbreviations. Instead of you, Y-O-U, we are just mentioning you, the letter. A-R-E-R, we are using R, U-R, Y-O-U-R, Y-O-U-A-R-E instead of Y-O-U-R-E. So these things, because now it becomes our secondary habit, and this thing we have been using in our scientific writing. Again, it gives a bad impression. The other thing, do not write as first person. Always write as a third person. And again, we have seen this thing very commonly. Like we normally say, our study is based on this thing. We found something new in the literature. Okay, so do not use we, are, I. Okay, instead of that, use as a third person. The authors could not find any study. Okay, the authors performed these tests. Okay, so always use as a third person. The other thing, do not use very basic non-scientific English like so, but. You know, these are the linking words, or when you're joining two sentences, instead of so, but, better to use words like therefore, whereas, whereby. Okay, so these are very, very basic thing, but at least for scientific writing skills, we should know these things. And there's a huge list of these words which you should not use. And what are some other linking words? I don't know how many of you have taken the IELTS or the IELTS test, because in IELTS there is essay writing and one is about the scientific writing. In that they want to see such type of the words, either they are using or you are using it or not. Okay. During the preparation of the manuscript, how you can write, what should be written first? As per my opinion, maybe it's totally up to you. Either you can agree with this or not. I always write methodology as the first thing. Okay. Second thing is results. Third thing is discussion. Fourth is introduction. And the last, I normally write the abstract. And before going to submission, I restructure or redesign my title. Okay, so when you are writing your methodology or your results first, there you can get the idea, like your discussion should be based on which topic or which thing. Like either you should focus it on any specific technique, or on your results, either it is a significant, non-significant. So you have to write your discussion on the basis of your results. So always write. Like this is you can make it your habit, like instead of going like first thing about abstract and then introduction and results. So you can rewrite it or redesign your habit accordingly. Choose of words specifically when you're mentioning the keywords and what type of the words you should mention in your title. Why it is important? Okay, getting the publication is one thing. Getting citation is another thing. Okay, like when I have these data available when I'm giving the presentation, like there are millions and millions of paper are available currently through PubMed, Scopus, and or through Web of Science. But how many these researchers, they are actually reading your journal or your paper? Okay, because when I'm doing any search or for my project, I'm using some keywords on either on Google or on PubMed. Okay, so these search engines, they normally go to or search these words in their title, abstract, or in keywords. Okay? So if you are designing or writing your title, these words should not be mentioned again in keywords, because this is one of the requirements of the journal, that you have to mention 5 to 6 keywords. So do not repeat those same words in keywords. In keywords, mention some other related words. So at least you can broaden up. Okay, it's the option is open for researchers like me when I'm doing search on Google or on PubMed. So maybe your paper will come up first, and I'll cite your paper. Okay, because again, in research field, it's sometimes it's an people, they feel honored, okay, that my paper has been cited like for 1,000 times, for 500 times, for 100 times, like, okay. So for these things, okay, in a very short way, I just mentioned like how to write a manuscript, but if you have any further question related to this, you can ask.
Yes, sir. Basically, most people were actually very curious about how to register the title of the study. For example, when you have formatted a title before you've started the study, but you have this idea, how can you register it specifically for a USA-based journal to prevent others from copying your idea?
Okay, yes, that was the question. Okay, when you are writing the research paper, then there is no need for this thing. Okay, but yes, when you are doing a systematic review, then there is a website. Let me tell you. Okay, I can't. I don't. It's. You can write it down. Its name. It's the Prospero. Let me tell you the full name. Okay, it's International Prospective Register of Systematic Reviews. Prospero is the website. You can search it on Google. So before writing your systematic review, or before starting your systematic review, if you have any idea, so you can register it over there. So at least you'll get the idea, like either it has been all like on this topic, someone has already done anything or not. I was reading a paper just while preparing this presentation, or just discussion, not presentation, yesterday. There was a paper related to this Prospero, and it was published in 2017. In 2007 till 2017, almost 30,000 topics have been registered on this website, and they were saying like in 2012. It was like this, that 12 topics or 12 titles per month, but in 2017 it was almost 800 titles per month. So if we are expecting like in 2020, obviously it will be more than 1,000. So for systematic review, it is the website is available. For clinical trials, if you before starting the clinical trials, you must register your clinical trial. Again, there is a website, you can go it on Google, registration of clinical trials. So it's clinicaltrial.gov. It's a USA based website, so you can register your clinical trial, because mostly when you are doing the clinical trials and you are submitting it in a journal, the journals, they ask this thing, that either was it a clinical trial, was it registered or not. Okay, so one thing is US based study, US based organization. Secondly, if you are familiar with this governmental organization, DRAP, Drug Regulatory Authority of Pakistan, they have, it is now officially, you cannot do any clinical trial if your topic is not registered with DRAP. Okay, officially and legally, you are not allowed to do any clinical trial. Maybe you are aware, just last week example, like about this COVID-19, a vaccine came from Australia, and they wanted to do clinical trials in Pakistan, and in Lahore, one of the university, they promoted this thing, and that they are saying that we are going to start clinical trials of this vaccine, and suddenly DRAP, Drug Regulatory Authority of Pakistan, they jumped in and they sent a letter to the authorities of that university, and they said that how can you start a clinical trial because you didn't get any permission from us. So it is applicable on dental based studies as well. So your studies should be, because if you're working on a patient, so your clinical trial should be registered. Regarding the research-based topics, there is no such thing that you are going to register your topic with any journal on any journal website. So the answer is no for that.
Okay, thank you so much, sir. Sir, there's another question a lot of people ask: how to calculate the sample size, particularly for quantitative research? What are the minimum patients and how can we go about it?
Okay. Very briefly, let me tell you about the difference between sample size calculation for quantitative analysis or the qualitative analysis. Okay, criteria for quantitative analysis. Sample size calculation for quantitative analysis. If you are working on any material-based study or something like this, there is a formula formulated by WHO. It was published in 1991, probably in one of the journal, and it is available. So what you should know related to your sample size calculation, one is the confidence level. Okay, like what is, either it is 90%, 95%, 80%, and then you can put that value in that. Secondly, the other things you should know, there are two ways. One way is that if you find any not similar, I would say, or something similar study related to that topic, so you can use the mean value or the standard deviation values of those results, and you can put it in that formula. From there you can find out the sample size calculation. Secondly, if nothing is mentioned in any journal, then you have to do the pilot study. Okay, and on the basis of that pilot study, you can get the mean values and the standard deviation value. There you can put in that formula, and from there you can find the sample size calculation. It varies for the quantitative analysis. It varies for every type of experiment, for every type of testing. Okay, some studies, if you're not, the other way is that when you're doing the quantitative analysis, especially on the lab-based studies, in ISO standards or sometimes the ASTM standards, American Standard Testing Materials, they have mentioned their specification that minimum number of samples you should use in your study is this. Suppose for the mechanical studies, they have mentioned that it should be more than 6. Like I'm just giving you the example. So you can give the reference of that ISO or ASTM specification, and you can say, okay, according to these specification, our number of samples are suppose 6. Okay, but the best way is that to use that specific formula and things you should know about the confidence level and all these things and mean values and the standard deviation value, and then you can calculate it yourself. Again, one more thing. When you're using such calculation, we have seen in our experience, the sample size number, sometimes it is just weird. Okay, like you are doing the mechanical testing, and they say, according to the formula, they said, okay, 100 samples per group, which is again logically it is not acceptable. Okay, so then you can say you can choose any good article from the literature, and if they have used 10 samples per group, so you can give their reference. Okay, according to that, on the basis of this reference, we also use the same 10 samples per group. For the qualitative analysis, if it is on the population based, so you should know what is the population. Like suppose you are doing any study based similar, like we have seen recently, many studies have been published based on this COVID-19. The assessment of dentists, assessment of the students. Then there you should know what is the population of dental surgeons in Pakistan. Suppose we say there are 25,000 registered dental surgeons in Pakistan. So from there you can calculate your sample size either based on any previous study or again based on the mean values or the standard deviation values. There are like three, four different type of formulas are available related to the qualitative analysis, sample size calculation of the qualitative based studies. Recently, we have seen many websites, they are doing calculation it for yourself. Last month, we did one seminar, and one of my colleague, he was the speaker, and he was mentioning that there is a standard table. From there, you can calculate or you can find it out your sample size. Like suppose if the population is 10,000, so your sample size should be suppose 400 or 500. Okay, if the population is 2,000, so your sample size should be like maybe 200 or 250, something like this. So there you can use these formula or these authentic references.
Okay, sir. Thank you so much. Sir, there's another question. What should we include in the cover letter when we're sending it to reviewers or editors?
Yes, that's very, very important. Very good question. Because and let me share my experience. Previously, like just a couple of years before, I usually write a cover letter with a very basic thing. Okay, like address to the editor-in-chief, mention their journal name and the publisher name, subject is this, and then I mentioned, okay, we would like to submit our manuscript or research article or review article, mention the title, and then just mention, okay, on the basis we would like to inform that there is no conflict of interest, there is no financial assistance was taken, and all my co-authors are aware of this publication, blah blah, just very basic thing. Then almost three years before, I had a discussion with some of the editor-in-chief of dental journals, and then I asked them, okay, what do you want from us? Then they mentioned that you should mention the significance of your study in your covering letter. As per his opinion, they said that the editors, they don't have time to read your full manuscript. Okay, because they are busy people and they are doing some honorary job for this. They are not getting money for this thing. Okay, so what they normally do, they only read either abstract and or covering letter, and from there they get the idea either it should go for the reviewer process or not. If you see, most of our rejections are just from the editor's table. Our paper, they don't go even for the reviewing process. The reason is that editor normally see the abstract or the covering letter, and from there they can make their mind either there is something in this paper or not. So in covering letter, initially when you mention that, okay, this paper we are submitting it for possible for evaluation, then in bullet points, do not write like paragraphs and paragraphs, but in bullet points, you can 5 to 6 bullet points, you can mention about the significance. If it is a clinical based study, mention what is the clinical significance of the study, or even if it is a material based, but material with any clinical application, you should mention what is the clinical significance of this material in future. Okay, so your 5 to 6 points, bullet points, will tell this thing to any editor that either this paper should go for the reviewing process or not. And then in last paragraph, you can mention the same thing, that either if you should not submit the same paper in 2 journals. It's ethically, it's wrong. I know people sometimes they do this thing. They are submitting the same paper in 3 different journals in the same time. Okay, and then they think not only, okay, if I'll get acceptance from journal, so I will withdraw it from other journal. No, this thing you should mention in your covering letter that this paper has been solely submitted in this journal. If you have taken any financial assistance, you should mention. If you have any conflict of interest, you should mention. You should mention name of your co-authors, and it should be mentioned that all your co-authors are aware of this publication, because sometimes it happens you are doing it yourself, and sometimes one of any co-author raise this query to editor that I don't know about this publication or this submission. Okay, so all these things, and then at the end you should mention all your details, your official affiliation, your email address, or any contact number.
Okay, sir. Thank you so much. Sir, another question. What are the do's and don'ts of proposal writing? And for example, if you're applying for a very good publication, for a journal, for example, that's international, we usually have, the price goes up to 3 lakhs or in dollars especially. So how can we get grants, and how do we apply for it? What are the memberships or the companies that we can apply to for that?
In Pakistan?
In both, internationally as well.
Okay, let me tell you about Pakistan. In Pakistan, there are few organizations like Higher Education Commission, Pakistan, Pakistan Science Foundation, and this Pakistan Medical Research Council. Okay, these three main organizations are available in Pakistan, where you can submit your research proposal for any funding. Okay, but the thing is, they normally entertain public sector universities. Very few private sector universities like Aga Khan, or maybe not, there are some other private institutes which are very good, like LUMS is there. There you can apply for funding, but mostly these organizations, they always go, because I was part of this thing, they always they prefer public sector universities. So in Pakistan, there are very limited options which are available to get research grant. Okay, that's unfortunately it is there. Secondly, it depends upon your university. Okay, like if you are doing some MDS project or MPhil project, some universities, they have or I know all these universities, they are charging for like either from government or from students. They are charging for this thing, that this amount will be spent on research project. If they are giving, it's good. If they are not giving, what can I say? Okay. The third thing, the companies. Again, unfortunately, the companies which are related to dentistry in Pakistan, they are actually distributors. They are not companies. Like all these big names, those who are distributing the products of 3M or Dentsply or Ivoclar or etc., 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 they all are distributors. They are not companies. But if you know your project is good and it can give a new information, then you can apply to these companies, to their R&D office, like to GC company, 3M company, Dentsply. Then they can say, okay, like your project is good enough, and we are ready to invest money on you. Okay, so this is the actually right now the current picture of getting funding in Pakistan. Pakistan Medical Research Council, they are good. They are giving funding, but they are mostly related to public health based project, not exactly for the for actual experimental studies related to in the lab or in clinics. The thirdly, from Pakistan, you can apply for international fundings. Like I applied it in British Council in 2013 and I got the funding. Similarly, some IFS is the Swedish-based organization. They are giving funding. Third World, what's the name? Third World Association of Science, which is originally started by Dr. Abdul Salam. They are giving funding to researchers. But again, they are giving funding mainly to public sector universities, or if it is an established private institute. And this is what, my first when we started this session, that's the thing, because unfortunately our private institutes, they are not developing themselves. Some of them, they develop, like Khan, for many years. They are getting huge amount of funding from these organizations, lumps. Now they are getting, I know some private universities in Islamabad, they are getting funding from international agencies. The reason is because they have established their trust on these organizations. Because if any organization is giving you money, okay, in dollars or in millions, they know either you are good enough to spend on these things or not. Okay, so in public sector universities, because the government is on the backside, so they can ask from the government or from that institute, where is our money? But in private sector, if it is not properly established institute, they can get money and just vanish. So that's the thing. So there are many opportunities available. Welcome Trust is a UK-based organization, and they are normally advertising these fundings, especially related to unfortunately, we are in third world country, developing country. So there are chances to get funding from there as well. Recently, in ComSets also, our center, they have got huge grant from this UK-based organization. And one of maybe our colleague Dr. Ali Khurram, he's based in University of Sheffield. He's oral pathologist. He got a funding, and he's been working in collaboration with some MaxPax surgeons in Rawalpindi or in Nust and in Shaukat Khanum. So there are a few organizations where you can apply to get these funding. But before that, you have to establish your yourself. Like suppose if you are new and you don't have any research background, and you are asking me that I'll give you 1 million, why should I give you? It's a very simple thing. But if you have a good CV, and I know, okay, you have a research background, you know how to spend this money, then I'll give you. So this is, I think, the response from my side for this question.
Okay, sir. Sir, so if it's a person who does not have a research background and they're applying for the first time, so it will definitely be harder for them, right? Unless if they provide a proper format of where the money is going to go and how it's going to be used, an estimate maybe.
Okay, for this thing, you have to collaborate with any established researcher. I'll give you the example. Sorry, I just missed it. One thing, IADR, International Association for Dental Research. If you are a member of this organization, there are many opportunities to get grants and fund and the fellowships even. So you can apply through their website, and if you're eligible, so you can get funding. Okay, related to your question, if you are new, you are starting your project, you are a young researcher, and you want to establish your thing, but you are not already established. So you should collaborate with some established researcher, and his or her name should be included as co-PI or co-investigator or as consultant. So with his or her name, the organization can maybe give you the money. I'll give you the example, like in 2010, I applied for the regional development program. It was a huge funding. I applied it to IADR, and I was new. Like before that, I didn't have any experience to get the grant, and the application was rejected. Right? Next year, I went to Leeds in UK, and I met the president of that organization, and I asked her, like, okay, I applied for this, and you didn't give me. Why? Then she remembered this thing, and she said, okay, your application was fine. Okay, we knew this thing that you want to spend on in Pakistan it was related to caries research, but you applied it yourself. You didn't include any researcher from established institute. Like maybe we applied it from Pakistan. Actually, I was the main PI, but it was a team project. You should include any researcher either from UK or USA, from any established university. Then we can give you a project. So it's a real example I'm giving you. So it happens in research.
Okay, sir. Sir, so in such a case as well, like when we're doing some research, how can we choose the reviewers and how can we reach out to them and how can we show them that they should, that we can be a part of it, like we are reliable to research?
Okay, reviewer for the papers.
Yes, sir.
Okay, yes, many journals now they are asking for this thing that you should submit 2 to 3 names of reviewers, and they ask for this thing that reviewer should not be your collaborator. You should not be a co-author in any journal in last 5 years. So the rule is that few things because it's recorded and it will go on. It's going on YouTube, so I don't know. I should give you the right answer or not. But the thing is, do not give name of big researchers or big dentists. The reason is because they are busy people. They don't have any time for your paper. So if you think you are giving the name of any big researcher and he's too good and I'm giving his name or her name as a researcher, they don't have time to read your paper. So maybe the editor, they will send your paper to that reviewer and it will be in their laptop or in computer for months and months. Then after the reminders, they said, okay, we don't have time. And then the editors, they will find another reviewer. So when you choose reviewer, it should not be from the same country. I'm not saying from same university. It should not be from same country. Like if you are applying from Pakistan, your reviewer should not be from Pakistan. Because that's the first thing, because editors, they know this thing that if you are giving any name from Pakistan, it means you know him or her. Okay, so your reviewer should be from any other country. As I earlier mentioned, you should not be co-author in any journal in any paper in last 5 years. So do not give their name. And the third thing, the reviewer should not be your collaborator in any project. Okay, so this is the answer. Otherwise, obviously, people sometimes they give the name. They know. They ask, okay, can I give your name as a reviewer? So if they give you the consent, so then you can add their name while submitting the papers.
Yes, sir. Sir, we also had this question. A lot of people get confused between the difference between a case report and a case study. So could you please elaborate on that, maybe?
Okay. Case report is basically single author or single person study, which is usually based on library activities or and something like this. Whereas case studies, when we are typically use this word, it means when we are doing any clinical work, okay, on a patient, like either is single case or a series of cases. Okay, it's the same. You cannot say same thing because when we are submitting any our clinical data, okay, that we did this thing and we found a huge ameloblastoma in patient's mouth and we dissected it and we did the biopsy and we found out, okay, so that's a case study. It's not a case report. Case report is usually a retrospective type of study or descriptive studies which we normally do. So like there's again thin line between people. Sometimes they confuse that they are doing case study, but they normally write it down that it is a case report. It is usually a case study. I know because when you are asking this question, if mostly in our participants, if they are clinicians and they are submitting their data, clinical data, so they should give the name of case study instead of case report.
Okay, sir. Sir, we have a lot of more questions pouring in as well from the participants. Dr. Shirvano wants to know, for a dental house officer aspiring to be a devoted researcher, even in the absence of adequate supervision, what would your suggestion and guidance be for her?
For research project or for
yes, sir.
writing? Okay.
For a research project.
Okay. Right. Okay. Because if you're new, then obviously you need a supervisor. Okay. If you're a house officer and you want to start any project, maybe you can get a supervisor either from the same institute or you can ask anyone from other institute. Obviously, if you'll start it yourself, You will move here and there. Okay, what is the job of the supervisor? The job of the supervisor is just to give you a direction. That's one very important thing when you are doing research. There are so many things which can distract you from your goal, which is obviously either in the form of publication or in the form of degree. So the role of supervisor is that he or she can give you a direction that you should follow this path. This thing should be included. This thing should not be included in your research. Okay, and on the basis of their experience, they can tell you, okay, where to go or which thing you should not include in your study. So if you are new, you are house officer and you want to start any project, I would say find a suitable supervisor related to your topic, either from the clinical side or from the basic sciences side, and then yes, you can start it from there. Because if you'll do it yourself, sorry, I'm cutting you. If you'll do it yourself, eventually you can do it, but it will take a long time. There will be a lot of waste of energy and time, or maybe money as well.
That's true, sir. That's very true. Dr. Amna Khan commented, I'm conducting a research on reasons for lack of research in dentistry. And amazingly, results say the lack of motivation is the major reason. What could we do, being in the academic sector, to attract students and fresh graduates?
You know, when I'll give you the answer, many people, they don't like me just because I've been educating this thing in different universities. I've been educating this thing when I was in part of PMDC committee, and like, my point of view is that if you want to do a research, or you want to bring research in Pakistan or dental research in Pakistan, you should change some rules, the basic rules, especially when you see the criteria of promotion in Pakistan. Unfortunately, it's not in any world like this that you, on the basis of 5 publication in non-index journal, and you become professor. Right? We are talking about 21st century, and just on the basis of 5 non-indexed publication, and will become professor. And once you become professor, you say, okay, fine, now I am professor, now I don't need anything. Because when you are doing research, very few people, they are doing with their own interest. They normally do on the basis of their requirement from the institutes, requirement from any organization, or the body which normally watch you. Problem is that when in PMDC, when they are telling you, okay, submit 2 papers, even if you are not corresponding author, you will become professor or associate professor. So you have to change this thing, like HEC did. Previously, before Dr. Ataur Rahman, when there was a University Grant Commission, it was same, like people, they get their promotion just on the basis of few publication. But when he came and he introduced this thing, tenure track scheme, they said, okay, in 1 year, if you are assistant professor, you have to publish this much paper in impact factor journal, like in Web of Science Index journal. Okay, so if you will not fulfill this thing, your contract will not be renewed. And this thing, it happened like in universities, like in NUST or in ComCerts or in any Pakistani universities. But unfortunately, it's not applicable in our dental institutes or in medical institutes. Okay, so the first thing is that you have to change these criteria. Secondly, people, they ask, okay, what is the incentive while doing the research? Every institutes, they should give some incentive. Like I know, like it happened like when I was in ComCerts, on the basis of each publication, we were getting a reward. Though it was like reasonable, not I would say small, but it was a good reward from the institute. We were getting reward from Pakistan Science, Ministry of Science and Technology. Like if you get a good impact factor publication, you'll get it. Similarly, here in Saudi Arabia, on the basis of publication, we are getting rewards. So same thing, either if it is not like we are not talking about 10,000 or 1 lakh or something like this. even if you are giving, or your institute is giving 5,000 per publication to faculty member, or 10,000, so at least there is some incentive for the young researchers. At least for the young, like for maybe for the professors, they say, okay, 5,000 and 10,000 is nothing for them. But for the house officers and for the young researcher, it is fine. Like if you get 3-4 publications per year, at the end you'll get 20,000 extra. So you have to bring such things, like first to change the criteria from the organization body like PMDC, or HEC should bring rules on these medical and dental institutes. Secondly, the incentives from the institute or from university.
Okay, sir. Okay. Sir, Dr. Jawad Tareen is asking, what is the importance of research and training? For example, for synopsis, can we write a review of old articles, or do we have to follow a new idea?
No, I didn't get his question. Like for the synopsis, they want to review the article.
Yes, yes, he's asking if it's okay to read articles or if they have to come up with a new research.
Okay, this thing happened, and let me tell you, usually when you're doing research, it should be new. Okay, it should be new. Like for any either clinical studies or basic science studies. So your synopsis should be based on a new topic or a new research topic. Recently, just because of this COVID, it happened it happened in many countries, including the Western countries, because this is the time when mostly the master students, or they usually submit their thesis, and they couldn't work in the labs. So here they gave them the option, okay, instead of doing a research project, you can do a good systematic review paper, which you can do it from your home. But in Pakistan, I know, especially for MPhil students, you have to submit, or even for MDS students, you have to submit a research proposal, not the review proposal.
Okay, sir. Sir, Dr. Mawish Salim is asking, why do international journals take a lot of time for reviewing or publishing the manuscript? She is a student in MPhil for dental materials.
Yeah. Yes, Mavish is still doing like MPhil with me, and it happened. Why it happened? Because we submitted our paper almost 2 months before, and Mavish, I just checked yesterday, and still with the editor. Okay, actually it happened. Mostly the editors, as I mentioned, the editors and the reviewers, they are busy people, and they are doing this job without getting any incentive. Okay, and obviously there is a huge load of papers on these journals, and especially in this COVID, like because the topic or title was dental research during COVID-19. We have seen during this time since March, because everyone is free, we're not going to the universities or their institutes, so they have time, so they start writing papers, either review papers, or if there is, like, even I did myself some of work which I did it in 2014 and 16. I couldn't write papers at that time, so I used that data and I wrote papers, and obviously I submitted it. So there is a huge load of papers on these journals. So obviously on the basis of that, they are taking a lot of time, and then obviously selection of reviewers. Sometimes reviewers, they don't have time. Editors, they are sending their paper to reviewer usually keep it for a couple of weeks, and then or 3 weeks, and then they say, okay, I don't have time. The editor has to search a new reviewer. So these things, they matter a lot for the delaying process.
Okay, sir. Sir, Dr. Ramisha Zahir is asking, where can we learn SPSS in a comprehensive way?
Where we can learn SPSS?
Yes, in a comprehensive way. Full course.
Yes, full course. Like in Pakistan, many, I think, people, they are conducting these workshops, and even in institutes, they are running these programs. Okay, to get the knowledge of statistical analysis. So either you can attend those workshops, those seminars, or maybe you can join any basic program related to this statistical or for the analysis. So this is what I would say. But usually I believe as a clinician, because we are not statistician, so we should know basic thing about stats. But obviously we need the support of biostat person. Okay, so you can ask them. I know in Islamabad or in Lahore there are many good biostat people, and they can help you in this regard.
Yes, sir. Thank you so much. Sir, there's another question by Dr. Mevish Pasha. She's asking if there are any tips for beginners interested in writing book chapters, for example, on nanoceramics.
For book chapter, usually it's by invitation. Okay, if you get the invitation from the editor, then yes, you can start. And what are the tips? It's basically book chapter is sort of a narrative review paper. It depends. Like if it is that chapter is for textbook or it is for reference book. Because obviously, if it is for textbook, then you have to write. You should know what is the like. You can't give so many things for the undergrad level. But if it is for the reference book, usually it is for the narrative review paper and then narrative review type. So first for the book chapter, you should get invitation from the editor. And then just like as you are writing any narrative review paper, you can follow the same pattern.
Okay, sir. Thank you so much. Sir, I think this is the last question for tonight. Dr. Mahnoor Nabil, what are some softwares you would recommend for the collection of research data?
Well, to be honest, I'm not using any, but they are available on Google. But I'm not using any specific search engine or any agents from any agency. So you can find it out from anywhere. To be honest, I can't give you proper answer for this.
Okay, sir. Thank you so much. Sir, with your permission, I would now like to conclude this session. Thank you
okay.
so
Thank you very
much.
much. Like, I'm so sorry because I don't know, like in this Molar topic it's a huge topic. There are so many things which can be done in related to the research. But as far as my knowledge, this is what I can say.
If
you have any question, you can email me if you need any assistance, any guidance, or any help. So my email address, you can share it with them. So whatsoever I can do, I can.
Thank you so much, sir. Thank you. It was a very valuable insight, and thank you for taking out such precious time all the way from Saudi Arabia. It means so much, and it has been a wonderful learning experience for all of us, and definitely very encouraging. I'm pretty sure a lot of emails will be being sent to you and asking a lot of questions about research. So by concluding this session, Dr. Amna, I would like to hand this over to you now.
Thank you very much.
Unmute. Amna, sorry, Dr. Amna, would you like to unmute yourself? Thank you.
I'm sorry. So thank you, Mavish, and thank you to Dr. Abdul Samad once again. That was very insightful. Research is much needed in Pakistani healthcare settings on Pakistani patients by Pakistani academics and healthcare workers. So I hope all our participants will benefit and implement the advice and knowledge they gained from this session. And this concludes our session for tonight. I would like to thank our speakers for giving us their time and valuable information and for joining us to share their experiences. Thank you to the participants for joining us. We hope that you have gained as much as we have through this session. Do not forget to fill the feedback forms, as certificates will be distributed based on that. Thank you, Mavish, for being an amazing co-host, and the rest of the team for helping us conduct this session. Our next session is going to be tomorrow on the 16th of August. Same virtual space, same time, where our guest speakers, Professor Musaddiq Khan and Dr. Javed Raza, will be discussing surgery in the time of COVID-19. See you all then. That's all from my side. Mavish, over to you.
Thank you so much, Dr. Amna. It was very wonderful hosting with you as well. Thank you to our speakers for sharing such beneficial information and taking out so much time to increase our knowledge. Thank you so much to all the participants for tuning in. A special appreciation post for Professor Samia Naimullah for all her efforts. She's our patron as well as our advisor for the academic team, and this series would not have been possible without her. Similarly, thank you, Dr. Sabah Akhtar, who is the backbone of our team. She's a co-founder of VFP and also the advisor for the academic team. Thank you, Mr. Iftikhar Yazdani, CEO of Rahil Qamar and a partner of VFP. His company provides voluntary IT services for this noble cause. Thank you, Dr. Rabil Tariq, co-founder of VFP. Thank you, Dr. Maham Khalid, who's the co-director of academic wing of VFP with me. Dr. Saheb, Dr. Ibrahim, and many others for supporting us throughout the session. Thank you on behalf of Team VFP, Team Yardim, and Team RMU. Allah Hafiz.